Okay, just in review, because I think we actually got a couple slides past this, but labor consists of 4 stages, and you need to be familiar with what happens at each stage, what your nursing interventions are, that type thing. So stage 1 is what we consider labor. Stage 1. So it has 3 phases: latent, active, and transition, and then you have stage 2, which is infant delivery. Stage 3 is placental delivery, and stage 4 is recovery. You alright? Alright, stage 1, latent phase. So stage 1 and the phase latent. Regular mild contractions that begin to intensify. Cervical effacement and dilation begins. They may be relieved that labor has begun, but anxious about what's going to happen. But they are usually excited. This is kind of a good time to do what? We talked about this last week. Teaching and that initial assessment where we have to ask them all those questions. It's kind of hard to ask somebody that's 8 centimeters, what religious affiliation are you, and do you have a living will, and all those questions that we have to ask to get our admission assessment done. They're not usually as receptive when they're having to breathe through a contraction to answer some of those questions. So, good time to get your stuff done. Contractions may be 10 to 20 minutes apart, but could be as close as 5 to 7 minutes apart. This stage can last how long? This actual phase may last 5 to 8 hours. And it could be drawn on. You do hear people say, I was in labor for 24 hours. Well, they may have been in early labor for an extended period of time before they went into active labor. Okay? It's a great time to complete the admission assessment. We talked about that. What about cervical dilation? 0 to 3. 0 to 3. Okay, so what's the next phase? Active is going to start with what cervical dilation and go to what cervical dilation? 4 to 7. Okay, good. Contractions increase in intensity, duration, and frequency. They're usually every 2 to 3 minutes apart, lasting 40 to 60 seconds. I think your book actually says 30 to 60 seconds. Contractions are now moderate to strong. This can last 4 hours or longer. The rule of thumb is what? How much should you dilate per hour? 1 centimeter. If you're primogravida, meaning this is your first labor delivery, then it usually takes you about 1 centimeter an hour, which gives them a rule of thumb. Does it always go like that? No. You could go much faster than that, or you could go slower than that, but that is a rule of thumb. That's what you should be doing, is 1 centimeter an hour, assuming that your contractions are enough to cause cervical change. The fetus starts to descend. So when the fetus descends, what do you think the patient starts complaining of? Nausea, but what else? They feel like pressure. They feel a lot of pressure in their bottom. So that is something that usually happens during this stage. If the baby's come down a lot and it's a different position, if it was a -2 station and now it's a 0 station or a +1 station, they're going to feel more pressure in their bottom. So we always tell them, if you start to feel any pressure, let us know, because that's a signal that we may need to check them again to see what's going on. Because we definitely don't want to come in and there be a baby in the bed. We'd like to have a little more control over it than that. So, increased anxiety. They fear that they're going to lose control because contractions are getting stronger. They may request or need pain medication. So what are some different types of pain medications that we can use during labor? Stadol and fentanyl, those would be IV medications. What other pain options do we have? Epidural. What if they're having a C-section? Spinal. Or epidural. Sometimes we'll use epidurals, and we'll talk about what's the difference. It's a different spot. It's a different spot. The epidural space is actually a created space. When they actually put fluid in, it expands that space. With an epidural, you can dose it really heavy and do a C-section. With a spinal, you're going to get that true, I'm numb, can't feel anything, whereas with an epidural, unless you dose it really, really heavy, they're still able to move. It just feels weird. But with a true spinal, they don't feel anything. There's a picture and it kind of shows you the space where they go. Now with a spinal, they actually do get spinal fluid back. They're in that fluid column. With an epidural, they're not supposed to get spinal fluid back. So it's a little bit different space.
Is that the one that if you move it can paralyze
It
you?
is, and that's a lot of the reasons patients don't want to get epidurals. I've never seen that happen.
But
It can happen.
Which one, the epidural?
Either one.
I always thought it was spinal block.
Either one, because they're not in that different of a space, and if a patient moves, you could actually, the needle would probably go further. Okay. All right. They can also do local blocks, which we don't use much anymore. By far, the two that we use the most are IV pain medications and epidurals for labor. But there are some local blocks or some saddle blocks, that type of thing, that we'll mention when we talk about pain management. They may not want to be left alone during this stage because they do feel like they're going to lose control. Alright, I think we actually got to this slide, but let's go over it one more time because I want to make sure that you're comfortable with this. IV medications, we talked about Stadol and fentanyl. What are the restrictions on IV medications? Or what would you tell a patient if they're wanting to do IV medication? Okay? It's not like on the floor where they have Demerol ordered every 4 hours and we can give it every 4 hours. It's a one-time dose and we have to call the physician to get another dose, which is fine. There's nothing wrong with that. But there's also a limit to when we will give them pain medication. If they are progressing, if they went from 3 to 7 in the last hour and now they're wanting pain medication, the likelihood that we're going to give them pain medication is slim because we don't want to give pain medication to mom right before the baby delivers because then baby's going to be depressed. If you, and I don't mean like sad depressed, I mean like respiratory depressed, okay? If you do give pain medication, and sometimes it happens, and then they progress really quickly after that, regardless of how long it's been, we typically make sure that we tell the nursery what time they last got IV pain medication. So when nursery comes up to set up for the delivery, we'll say, Mom had IV pain medication an hour ago. She had 25 mics of fentanyl, or whatever we gave her, okay? So that they know. Why do we need to tell them? Because they have a box that they can actually pull some Narcan out of if they need it. So they would probably go ahead, especially if it's been in the last hour that we've given mom pain medication, and pop that box and have it ready in case the baby did come out and the respiratory rate was down. They could go ahead and take care of that. Okay? Depends on how fast they're going. If they came in at 2 and now they're 7 and that happened in an hour, then it may be 7. If they came in 12 hours ago and they haven't been making much cervical change, you may actually give them pain medication at 8 centimeters. So a lot of it, 8's kind of that iffy point, but a lot of it's going to depend on the big picture of how quickly have they been progressing. And if they've been progressing really fast, then yes, they would not get any at 8. Okay? The other thing is when we're giving IV narcotics to a mom that's laboring, when do we actually push that medication? At the peak of the contraction. Why at the peak? Because think about what's happening in that uterus. Everything is contracted down. So that is your window that baby will get as least of that medication as possible, if that makes any sense. So at the peak of the contraction, you give it slow IV push. Okay? Good. Will the IV medications completely relieve their pain? Will it make them drowsy? Yes. So a lot of times what you'll see is patients will say, why is it not taking the pain away? Well, it is taking the edge off the pain, and it probably is helping more than they realize, but they still feel the contractions. They sleep in between them, and they wake up and feel another contraction. So it does not completely relieve the pain, and they need to know that going in. Because if they're thinking they can get a shot of fentanyl and sleep for 4 hours, that's not the way it works. It just doesn't work that way, okay? So they need to know that. All right. I think we talked about all that. All right, natural labor. What does that mean? To us, to a labor and delivery nurse, it means no meds. But that's not always what it means to the patient. So when they come in and they say, I want to do natural labor, you need to ask them what that entails. because that could be position changes, they want to get in the shower, they want to use the birthing ball. It could be all of that, and no IV pain medication, no epidural. Or it could be they just want IV medication. We've seen a lot of patients come in and say, I just want to do a natural labor, but I want some IV pain medication. And that's different than what we typically think of. So when they say they want a natural labor, what do they mean by natural labor? And what does that entail for them? Okay? All right. Let's see what else I can tell you. I'm going to break epidural off separately. I'm going to talk about general anesthesia here just a little bit. Of course, we don't knock people out for labor. We do use general anesthesia occasionally for C-sections, however. So I'm going to go ahead and talk about it here briefly, and then we may mention it again when we talk about sections. We don't use general anesthesia much. You may think of some reasons that we would not want to use general anesthesia. Because you're giving mom a lot of medicine, and so it can affect the baby. So there's a small window there between when they actually put mom under and you get that baby out. So it definitely makes it a little bit more of a, hey, we got to get this baby out situation. And those babies can come out to be respiratory depressed because what have you given mom? A lot of drugs to just completely knock her out. So we don't use it that much. We do occasionally use it in emergency situations, which sounds kind of counterintuitive. But you can't section a mom with no anesthesia, and the quickest way to put them under is general. If your baby's in the tank and running a heart rate of 60, you may not have time to sit her up, put an epidural in, dose it, make sure she's comfortable. So they will sometimes use general anesthesia in emergency type situations because it gets mom out quick so that we can get the baby out quick. So there's a double standard there. If they're using general anesthesia, a lot of the times now, if it's a controlled thing where they're using general anesthesia, if it's an emergency, you probably won't have time for this. But they usually give them either Bicitra or Tagamet or Pepsid before they go down for surgery or go into the OR, because what is the risk that you run with general anesthesia? Aspiration. Okay? So a lot of times they will give them that to kind of take care of their GI content, hopefully keep them from getting sick on the table. Because if they start vomiting and they don't have a gag reflex, or they don't have the ability to spit it out, they can actually swallow it back into their lungs. So you will see if they're going for a scheduled C-section where they're going to use general anesthesia, which I promise almost never happens, but if it does, then they usually give them Tagamet, or we use Pepsid and Bicitra are the two that we use at the hospital. Okay. Sometimes they will even give the Pepsid and Bicitra if they're doing a spinal, just because they're going to be flat. Okay. Pepsid, Tagamet, Bicitra, and it's to help the stomach acid. And y'all should have already, I'm sure y'all are familiar with Pepsid and Tagamet are the same classification of drugs. So is Bicitra, so just decrease stomach acid. Alright, regional anesthesia that you may see used, or regional medications, they can do local. When do you think they might actually inject lidocaine into a patient for labor, for an episiotomy? So sometimes they will use a local injection in the perineum to repair something or to perform an episiotomy. And that's just like it is when you go get a tooth filled. They just use a needle and they actually inject it into the tissue so that it is numb when they cut or when they repair a cut. If they have an epidural, they may not use local anesthesia. But if they don't, they will. Sorry, y'all. That's Brad. Is he not here? Okay. Alright, pudendal, P-U-D-E-N-D-U-A-L. P-U-D-E-N-D-U-A-L. It's usually used during the second stage of labor, and it numbs the vagina and the perineum. But it doesn't numb the cervix, so it just numbs that outer tissue. They used to use this a lot more. We don't use it much anymore, but I wanted y'all to be aware of what it was. So it's used during second stage to provide some pain relief to the perineum, but it's not going to take the contraction pain away. Okay? I think I said cervix, but I meant contraction. Did I say cervix? I did, didn't I? Let me repeat that. Used during the second stage to take some of the pain away of the perineum in that area, but it's not going to stop the contraction pain because it numbs down below. It doesn't numb up here where they're actually feeling the contraction. So it's not used that often. Pudendal. This would be more regional, where the injecting lidocaine to the perineum to actually repair or perform an episiotomy will be local. This is going to be regional. Okay. Alright, what are some other pain management ways that we talked about last week that are non-pharmacological? Effleurage, which is, it's like a light massage. It's not what we typically think of as like a true massage, but it is a massage technique. But it's where they usually do figure eights or circles. Just think about when your kids' bellies hurt, what you do. You kind of rub their bellies in a circular motion. That's effleurage. That's what it is. So it can be used during labor as well. What else? Water is very comforting during labor. Sacral pressure is awesome. Massage, breathing techniques, guided imagery, aromatherapy. We do have patients that come in and bring aromatherapy to kind of have a calm environment, and that's fine too. Okay. All right, so let's talk about epidural. All right, looking at this picture, where do they typically perform an epidural? In the lower back, usually the lower lumbar spine. And you can see there L4, some running there. All right, I do want to kind of just show you these pictures first. You can see here that they're actually going to thread this in, but what I want y'all to know is this is what's left in the patient's back. Because a lot of patients come in and they say, I don't want a needle in my back. Well, there is a needle that's there for a short period of time until we can get that little thin catheter in. But once that catheter is in place, there's not a needle that's left in the back. So once the procedure is finished, it's not like you're going to get paralyzed from it after they're finished, because that's a flexible catheter. It's not like a hard, rigid needle. Does that make sense? And a lot of times they don't understand that. They don't know that because, I mean, it's not like they have an education course on epidurals while they're pregnant. They don't, unless they go to a prenatal class. So they need to know that when they come in. All right. Let's just go through this. Okay. If a patient starts to request an epidural, is there anything that the nurse needs to do when they want an epidural? They need to sign a consent, and they need to sign a consent form prior to receiving IV narcotics. So usually we try to do that up front when they come in. You know, this is your epidural consent. It doesn't mean that you have to have it, but we'll have it on the chart if you need it, because if you take IV pain medication, you can't sign it. Okay? What else does the nurse need to do? Some of y'all that have been in labor and delivery, what does the nurse go in there and do before they come in to do an epidural? Fluids. The epidural tends to drop the blood pressure. So patients need about 500 to 1,000 milliliters of a fluid bolus prior to the insertion of the epidural or spinal. 500 to 1,000 cc's of fluid prior to the insertion of the epidural or spinal, either one. Now, why do you think you have a range there? If you've got somebody with high blood pressure, do you really want to pile on some fluid? If you got somebody with heart problems, do you really want to go in there and bolus them with 1,000 milliliters? So you do have a little bit of fluctuation there. But if it's less than the 500, if there's a reason that you gave less than 500, anesthesia needs to be aware of that. Okay? It would be a bolus, like as fast as you can get it in. Mm-hmm. Mm-hmm. Yeah, next of kin would have to sign. And usually we just try to deal with it up front because it negates that. You don't have to worry about it. You don't have to say, oh, she can't sign it because she had fentanyl an hour and a half ago. Just get it done up front. Anesthesia usually comes and talks to them pretty close to when they get there. So I did hear you got to wait till they're 4 centimeters. That is probably going to be hospital specific, but most of your hospitals now don't have a mandatory got to be this amount before you get your epidural. You just call a physician and say she's 2 centimeters, she's hurting really bad, she wants her epidural, and 9 times out of 10 they're going to let them have their epidural. Most of the time, because we have drugs if they stop contracting or their contractions slow down that we can cause them to start contracting again. So that is usually what everybody says. Well, I heard that it slows labor down. And I'm not going to say that the research doesn't in some ways support that, because it does. But a lot of times people wait until they're 6 or 7 centimeters and they're so tense that that epidural allows them to relax and they actually speed up. So there's 2 ends of the spectrum on that. So there's not usually a, hey, you got to be this before you can get it.
Yeah, if you were planning on, if you go into the hospital planning on getting an epidural, when you get in there, can they go ahead and press you for that and like go ahead and put the
and just not dose it?
Not dose it?
They usually don't do that, and they just do it all at one time. Like when you start hurting, they'll just put it in and they'll go ahead and dose it. I'm not going to say that you wouldn't potentially see that done occasionally, but that's not the norm. Okay? All right, the other thing that we have to have is we have to know their platelet count. So what is your normal platelet count? 150,000 to right around 350,000. So if their platelet count is 234,000, are we okay? If their platelet count's 150,000, are we okay? If their platelet count's 100,000, are we okay? Most of your anesthesiologists will not put it in if it's less than 110. Some of them will as long as it's not less than 100. But anyway, if it's without that, not within that normal range, it needs to be reported to anesthesiology because it will be their decision as to whether or not they feel comfortable placing that epidural. Why would we need to know the platelet count? What about that procedure is going to make us have to know what a platelet count is? Because if they don't have a high platelet count, what can happen? They can bleed. Okay? Because your platelets are your little sticky things that stick together to stop a hole. So if they don't have an adequate platelet count, they can bleed. So if they have a low platelet count, it needs to be reported to anesthesiology, and then it's their decision as to whether or not they will put the epidural in. Okay? Alright, so once you've got the platelet count, you've got your consent form signed, anesthesia's in-house, you've already given them the fluid bolus, you're going in the room to do this. Okay? What position do we need to get the patient in? Dangle position, where they're sitting on the side of their bed and they need their knees as far back on the bed as they can get it. So their legs are hanging off, but they're in a dangle position. Or you can do it in a side-lying, more fetal position where they're curled up. By far the majority of the time we do it in a sitting position. Okay? So dangle position, they need to relax their shoulders. They can't be like this. They got to relax their shoulders. And what we typically tell them is, make a C with your back, but don't do this. Don't curl your shoulders up. They need to relax those shoulders down. It's kind of like a mad cat on Halloween. How they push their back out. Same principle here. And they'll feel around on their back, and what we typically tell them is push your back out where you feel like they're pushing on you. Because the more space that they can open their back up, the easier it is to get the epidural in. Okay? So dangle position and a C position where they're curled around the baby, where their shoulders relaxed. Okay? And then you just have to kind of tell them what's happening with the procedures. You're going to need to make sure that you put the blood pressure cuff on them and the O2 saturation monitor for a couple different reasons. We already said that it can drop their blood pressure pretty quickly, so they will do blood pressures every 5 minutes while they're doing the procedure. And you need an O2 sat monitor on because that picks up mom's heart rate. And a lot of times when you're sitting in that position, you lose baby's heart rate and start picking up mom's heart rate. And you need to be able to determine if that's what you're seeing on the monitor or is your baby dropping. So there may be a period of time there where you can't trace the baby effectively, but you need to confer that, yes, it's saying on there my heart rate is in the 90s, but my mom's heart rate is in the 90s. So I can concur that that is my mom's heart rate that I'm picking up because they're the same. Okay? So O2 saturation and blood pressure.
So the O2 stat really not really measuring the oxygen, and you're just monitoring
The heart rate. And you'll see when we actually get in the procedure, that's just as important. You've got to know what mom's heart rate is. Okay. Alright, so once they do that, they're going to actually clean the back with these little spongy things. How many of y'all have seen an epidural? And it feels like, and you probably heard the nurse or the anesthesiologist tell them, it feels like a cat's licking your back. Those little scrubby things are rough like a cat's tongue. So they'll say, it's going to feel like a cat's licking your back, but they clean it. So check with them to make sure they don't have an allergy to betadine. They put this nice clear drape up so that everything's nice and sterile. And once they're at that point when they say, okay, I'm fixing to start, that's when they don't need to move. So that's when the nurse is going to say, I know you're going to feel a contraction, but we're going to breathe through it. You can squeeze my hand. Here's your pillow, because we'll usually put a pillow in their lap to let them curl over, and the nurse will stand in front of them. They get in a good position, they'll do the local, so they'll numb it up a little bit, and that's usually the hardest part of the procedure as far as the patient's concerned. That's usually the last thing they really feel. So they numb it up really good, and then it just feels like they're pushing on their back, like they're trying to push them off the bed. Now what they're really doing is putting a needle in their back, but the patient doesn't feel that because they're numb. They just feel the pressure of them pushing. So the hardest part for the patient is usually the numbing medicine because it burns really bad. Okay? Alright. Once they do that, what they're going to do is they're going to advance that needle until they get into that space that they need to be in. They're going to give them a little, sometimes they'll go ahead and thread the catheter. And then they'll say something like, I'm going to do a test dose. And when you hear that, that's the nurse's cue to, hey, I need to document that we're doing a test dose. But you're going to look at the heart rate of the mom, because what they're doing is they're giving them medicine to make sure they're not in a vessel. And it's usually some form of epinephrine. And what is epinephrine going to do? It's going to increase the heart rate. So if your mom's heart rate's running in the 70s, and after that test dose we're in the 130s, then guess what? We're in a vessel. Okay? So you'll see, yeah. So they'll do something, they'll usually go ahead and put the catheter in, or they may do it through the needle, and they'll say, I'm going to give a test dose. And so you'll look at the heart rate on your mom and see what it is, and you'll say, well, her heart rate's running in the 90s. They'll give the test dose, and what they're looking for is, do they have any elevation in their pulse rate? Okay? So if they gave the test dose and it was running 80s before and 120 to 130 after, then they can assume that, yes, they were in a vessel, and that's not a good thing. So they would have to redo it. They will also ask them to tell them if they get a metallic taste in their mouth or ringing in their ears, because that's another way they can tell if they're in the wrong spot. So they look at heart rate, metallic taste, ringing in the ears, any of those things. If the patient doesn't get any of those, heart rate doesn't change much, then they will go ahead and tape the catheter down. And they do this with a lot of tape. They put a little sticky thing over the insertion site. They tape it 3 or 4 times. They come up the back, so it is taped as securely as possible. Because is there a suture holding that in? No. There's nothing holding it in other than that tape. So when the patient moves in the bed, they need to be mindful of that. They're not just rubbing that tape off, because that's what's holding that catheter in place. Okay. It's just a straight catheter. So if they're in a vessel, they have a metallic taste or any ears and a high heart. And if that happens, then they would have to start over. They have to do a different one. But assuming that everything went fine, they would then tape everything down, and then they would give them a first dose of medicine to actually give them some pain relief.
What did you say the name of the test was?
It usually, we just call it a test dose, but it has epinephrine in it. I don't know that I don't think boards will ask you a question on that. That is what it is. That's what causes the heart rate to go up. Okay. So once we got the epidural in place, we still usually do blood pressures about every 5 minutes for the first 15 minutes, and then every 15 minutes for a couple hours or an hour or two, just to make sure that it's not going to drop your blood pressure.
Every 5 minutes more?
It's usually every 5 minutes during the procedure, every 5 minutes for the first 15 after the procedure, and then you usually go to every 15 minutes. Once they've had it for a couple hours, you may even see nurses go to every 30 minutes because the chances of it dropping the blood pressure at that point are low. But that initial hour afterwards, you got to be really careful. So every 5 during the procedure and immediately after the procedure, and then every 15 after that. Okay. All right, let's talk about some of the advantages or just some things about epidurals that you need to know. Does it take the pain away of the contractions? It should. It should. Now it does work by gravity. So if that patient lays for 4 hours on the left side may be good and pain-free, and the right side may be hurting. So you do have to change positions to keep that epidural even. Because if they lay on one side for an extended period of time, the benefits to the other side are going to be decreased. Does that make sense? You can, however, sometimes have a hot spot. And it may be the size of the end of this marker. But that one spot hurts. Nothing else hurts but that one spot. And it's just because of the way the epidural works by gravity and how the nerve endings are, they could potentially have a hot spot. But if it goes like planned, you really shouldn't have any pain with the contractions. And typically what they'll say is right after, they'll say, oh, I feel that contraction, but even though it's still going, they don't feel it. It doesn't last as long for them. So it doesn't last as long, and then it just eventually goes away. And they'll be like, well, I know I'm having one because my belly's hard, but I don't feel it. I don't hurt. And that's what you want, okay? Does it take away pressure? No. That's the good thing about epidurals, is it does take away the pain, but it does not take away the pressure. So they will feel when that baby's head starts to move into the pelvis, and that's a benefit to them. It teaches them when they would need to push, because when they feel that pressure, that means they're having a contraction. But it also will alert us if they start to feel a lot of pressure that we need to check them because they could potentially be ready to push. Okay? So takes pain, not pressure. A lot of times what they will do is give them a dose through the syringe when they first put it in. And then we will do something called a continuous dosing. And this is what keeps them comfortable throughout labor. And that's a lot of times what patients don't understand. They say, well, I've heard that the epidural can run out or it can stop working. Well, that shouldn't happen if they're on a continuous epidural because they can continuously they are continuously getting some medicine. It works the same way as a PCA pump, and usually it's set up that way where they get a little bit continuously to kind of keep them comfortable. But they have a button they can mash, so if they start hurting, they can mash the button. Okay? Here's the restrictions with that. If they can't move their legs, they don't need to mash the button. And nobody needs to mash the button for them. Okay? Because you do have support people that trying to be nice and keep them comfortable will just continuously mash that button every time they can have it. But if they can't mash it themselves or they can't move their legs, then they should not mash it. Okay? With an epidural, they should be able to move in the bed. It just feels like their legs are asleep. But they can still use them. They feel funny, but they can still use them. Okay? We talked about that it does decrease the blood pressure, but the reason that it does that is is because it causes dilation of the vessels. That's what actually decreases the blood pressure. So the fluid bolus before that is to hopefully prevent that drop. When you stop the medicine. So the whole time they're in labor, typically what we do is we let them use the epidural the whole time during labor. Once they're delivered, and if there's a repair, we let them use it. We mash their button so they can have the repair done. Once everything's finished, the bed's back together, and everything's good, then we would take the epidural down. And it takes about an hour for them to feel somewhat normal and be able to function and get up. Because even though they can still feel their legs and they can move their legs in the bed, if you stand them up, they can't support their weight. So they will hit the floor. So they do have to stay with us for about at least an hour afterwards until we can make sure that they can get up and at least shuffle to the bathroom. Okay. Alright, so we talked about that. I did mention labor progression, but just to kind of reiterate that, there is some research that says that epidurals does slow down labor, but there's also some real-life knowledge to support that it can actually help speed up labor. Depends on the situation. And a lot of times, if you've got a patient that came in for an induction, they're already on Pitocin. So if it makes their contractions a little bit slower, then just up the Pitocin. Now they're not hurting, and you have the freedom that you can do that. So if they're 6 centimeters and they've been hurting for 12 hours, then getting an epidural may actually relax them enough that they can just go ahead and their body can take over and do what it needs to. The epidural itself does not make them drowsy, but 9 times out of 10 your patient will fall asleep after they have the epidural. It's not really the epidural that's doing that. It's just exhaustion from working that hard, and now they're not hurting, so their body relaxes and they go to sleep. But there's nothing in the epidural that makes them sleep. I mean, it does have some pain medication in there, but it's not the same as giving IV pain medication. Okay? Alright. With an epidural, they should not get any spinal fluid back. If they were to accidentally do what is not so lovingly referred to as a wet tap, that means that they went into the spinal where they would have went to put a spinal in. And so now they have spinal fluid coming back out. The problem with that is they may get a headache. And it's called a spinal headache. So if your patient has had an epidural, and usually it's reported to us if they did a wet tap, because we need to know that, but let's say it wasn't, and your patient sits up and they have an excruciating headache, but you lay them down and it goes away, that's a spinal headache. And it's from the losing some spinal fluid, so those meninges get irritated and they get a really, really bad headache. But if you lay them flat, the spinal fluid kind of evens back out, the headache goes away. You sit it up, gravity drains it back down, they get irritated again, they start having a headache. So if your patient has that, it needs to be reported to the anesthesiologist immediately, because they're probably going to have to do what's called a blood patch. As far as we're concerned, we try to keep them as flat in bed as possible and give them caffeine, because caffeine helps. The blood patch will be done by the anesthesiologist in much the same way as they would do an epidural. They draw some blood from the patient and basically they inject it to patch the hole, is what they do. So that'll be done after they deliver. Okay? Alright. Your epidural uses a little bit bigger needle than your spinal, so that's why with a true spinal, they don't typically get a headache because the hole's much smaller. An epidural needle is much bigger. Alright. Let's talk about the spinal. The procedure is pretty much the same for an epidural versus a spinal. We don't use spinals for labor because those are tend to be reserved for surgery where they need to be completely numb, can't move their legs, that kind of thing. Okay? But the procedure is the same. They're in the same position. They still give them a fluid bolus. The difference is they do put a small needle in, but there's no catheter left in. They put the needle in, they put the medicine in, the needle comes out. So there's not a continuous, we don't do continuous spinals. Does that make sense? We do continuous epidurals. Different space, has a catheter. Your spinal, you just put in a small needle, they give the medication, the needle comes out. The spinal's going to have an X number of period of hours that it's going to work, and then it's going to wear off. So you do have a window there of, hey, I got to have surgery. This is when I need to do it. Okay. It works very fast. It works faster than the epidural. So you will see when you're in labor and delivery, when they do the spinal, they don't waste much time from when they put that spinal in to when they lay that patient down. How many of y'all have seen that? It's like, okay, let's lay her down, get her down, let's lay her down, because we want it to be an even spinal. We don't want it to, we want it to work. So they typically, it's very rapid. They lose sensation in their legs almost immediately. Okay? We talked about spinal headache. Alright, so what questions do y'all have about epidurals and spinals?
How long do you have to lay down flat on your back with a spinal doc?
Depends on the drug that they use. Like our spinals that we use in labor and delivery, we will usually set the head of their bed up in recovery. We won't put them straight up, but we will set them up enough that they can hold the baby. Sometimes it can be 6 to 8 hours, depends on the medication. That's not usually what you see in labor and delivery, though. Why do you think we keep them flat? So that that little hole has time to repair before you start putting them up. But like I said, the spinals do use a much smaller needle, so it's. But you will see some of your med-surg patients have to stay flat for several hours. Okay.
I have a question about the platelets.
Okay.
If you have low platelets, that's when they can breathe?
Yes.
Okay. What about high?
It would clot. So there is a danger to having low or high. We typically don't see a lot of patients with high platelet counts. It's very rare to see that. But we do have patients that have pregnancy-induced thrombocytopenia where they actually do have low platelets. So, okay. All right. If their blood pressure were to drop with either one of these, because sometimes it happens, they will usually increase the fluid. They'll give them another fluid bolus. So let's say right after the epidural, if the blood pressure dropped, they would give them a fluid bolus, as long as medically they could. They'll put them on the left side, because why would you put them on the left side? Because you want as much blood flow to get to baby as possible. Put them on some oxygen. Monitor the fetal heart rate, because if something's going on with mom's blood pressure, one of the first symptoms you'll see is the baby's heart rate. It's going to go, it'll either go into that marked pattern, or it'll start having a decel, or it will have a massive decel. So if you ever see that right after an epidural, you better go check your mom's blood pressure, because chances are the blood pressure is dropped. Okay? So a lot of times the first symptom that you see is the baby's heart rate drop before even mom starts to feel funny. And then they can give them some ephedrine, and that is an IV push drug to increase the blood pressure. It's diluted in, I think, 10 cc's of saline. The nurses can give it. Sometimes we give it, but the majority of the time the anesthesiologist is the one that comes in and pushes that drug to increase the blood pressure. Ephedrine. Not epinephrine. Ephedrine. This is a different drug. Mm-hmm. Okay. Is that a lot of information?
So the epidural and the spinal work the same way, it's just the spinal takes the needle when it comes to getting in.
The spinal has a little bit smaller needle. It goes into a slightly different space. It's going to give you that more completely numb feeling than just the, hey, my legs are asleep. And it's usually just used for surgery. We don't do spinals for labor.
How long did you say that the spinal lasts?
Depends on the type of blocking agent that they use, but it can last several hours. And to be completely normal, it may be 6 or 8 hours. Like a lot of times before they leave recovery after a C-section, they can grossly move their legs, but they don't have a lot of fine motor movement. Like they can kind of bend their knees up a little bit, but they can't wiggle their toes. So usually it just takes a while, and that will gradually come back, and then they'll just feel normal.
So when you say spinals for surgery, you know, like a patient having a
like they're having a C-section. Now, we use spinals for other things, but in the OB arena, spinals are going to be for C-sections. You can, however, use an epidural for a C-section. It just has to be dosed really heavy for that patient. So if you had a patient that had an epidural that was laboring that then had to have a C-section, they wouldn't take the epidural out and put a spinal in. They would dose the epidural. But they have to dose it what we call pretty heavy to make sure that they don't feel anything. If they're scheduled C-sections, spinals. If they are a laboring patient that turned into a C-section, epidurals. So if they just came in to have a C-section, we'll usually use a spinal. And we would greatly prefer using a spinal over general anesthesia just because not only do you have all those risk factors we talked about earlier, but they don't get to bond with the baby, they don't see the baby when it's born, so there's some bonding issues with that as well. Okay.
Do y'all let the dad or whoever come in under general?
They will usually let them come in if it's a non-emergent case. Like for some reason, if we did general anesthesia in a non-emergent setting, then yes, we would let dad come in. If it's an emergency, then no. And usually if it's an emergency, we don't have any family member in there, just because it's often very traumatic for them to see. It's not, y'all have been in labor and delivery, it's not a gentle case when they do a regular C-section, but you can imagine if it's an emergency that it's a little bit more stressful. Let's just put it that way. Okay. Alright, any questions about epidurals, spinals, general anesthesia, local anesthesia, any of those before we move on? So let's just reiterate this and then I'll let y'all take a break. How about that? When do we use spinals? If they're having a scheduled C-section. For OB parameters, if they're having a scheduled C-section. What's the advantage over a spinal versus an epidural? The needle's smaller. It works really fast. They're completely numb from about here down. They don't numb the diaphragm. If the diaphragm is not functioning, what happens? They can't breathe. So it numbs from above the belly button, right above the belly button down. But where do they actually make the incision? The lower abdomen, so it should cover that. And we'll talk about how they make sure that they're numb when we talk about C-sections. Works really fast. It's a smaller needle. And a lot of times if they're doing spinals, they'll... Is that thunder? If they're doing a spinal, a lot of times they would put a medication in there called Duramorph, and it's a long-acting morphine that lasts for 24 hours. So just everybody make a note, tell Ms. Capeless to go over Duramorph when we talk about C-sections. I don't know what that is. But the good news is, this is the safest place to be. We have no windows and we're in the basement, so we're good. So we're just going to keep on lecturing until we lose power. Then we'll worry about it. Duramorph lasts for 24 hours. It's a long-acting morphine. That's somebody doing something. I don't know what they're doing, but that's what it sounds like. Somebody's doing. So just make a note that we're going to discuss Duramorph when we talk about C-sections. Okay? All right, with the epidural, what is the advantage of the epidural? You do. You can make it last longer because you can actually, they have that little catheter in place so they can actually continue to get medication through that. It's not going to have that 2 or 4 hour window that a spinal is going to have. It's going to have, however long you give a medication, it should work. And it also gives you the advantage, should you need to take them to surgery, you can dose it heavier and actually perform a C-section with an epidural in place. Mm-hmm.
Back when my sister had her first baby,
Mm-hmm.
they gave her something called twilight sleep because there was a lot of complications.
That's probably Versed.
I don't know what it was. I was mom asking.
It's probably Versed. Usually, once the baby's out in the C-section, if the mom's not breastfeeding or if she wants something to help her relax, they will give her something, and usually it's Versed. So I'm assuming that's probably during labor.
She couldn't come out, but he was already. It was awful.
It could have been Versed. I mean, if you've got a trained nurse there, we don't typically dose Versed now, but they could have in the past. I mean, that's going to make you just care less about what's going on, which is probably what they wanted. So. I will talk. I will get off. Hang on.
In the real world.
Makes me not record that.
That's where I had my first one. That's what they said. And I hope that one thing about me probably knows it.
Our clinical paperwork, this is from the first picture that's from yesterday, and then this is my surgery.
Okay, just take that note.
Can I make a small announcement for the time?
Yeah, go ahead.
Okay, I know that we had planned to, we had talked on Facebook about doing something this Thursday, but since we have Miss Capeless this Tuesday, some of us thought it might be better to have it next Thursday. That would be after a test. You do? Okay. I mean, we could go forward with it this Thursday after Miss Brown's lecture, or we can push it back 2 Thursdays. So, we don't want to put you in a bind, because that's 2 tests,
Well, I don't really know what we're doing.
It's the collective birthday parties for September birthdays. There's Carrie's, there's Tiffany's, there's Heather's, there's Donnie's, there's Dana, there's a whole.
I think we're going to try to do this once a month for everybody.
For every birthday, except for November, because November, there's 2 weeks and then we're out, and then when we come back, I know. So I think we were going to do November / Christmas party.
My birthday's November 10th, and we got a test that day.
See, yeah, and then we're out.
That could be my birthday present.
Well, yeah. We'll be out for that whole week in November, and then when we come back, it's finals. So that'll be rough. So it's just better to
I need to go to Columbus.
push
One of our
November.
very best friends was in a car accident, punctured lung, broken ribs.
You didn't know about Brad? I was fixing to tell because Kyle called me to say
Right, that's why Brandon was coming.
they're moving into
He called
ICU.
me earlier, and he couldn't get there, and I started, he was out in the parking lot.
They're going to move into ICU. Brad. Leaving Cleveland County, officiating a volleyball game.
Brad, who?
Brad Young. He's from Woodland. He's Kyle's cousin.
All right, so party.
Okay, let's take a class vote. Madam President, with your blessings.
Maybe I can't take you.
Bye. Hey, Beck, I'll text you because, they're moving him to ICU and
I'm
he's
going back to
staying.
Manila, and we're getting together in one vehicle and going, so
Okay.
we're heading up there.
Okay.
As soon as I get there,
All right.
know something doesn't make you wrong.
Okay.
Be careful.
So, all in favor for this Thursday? Let's get a show of hands. This Thursday. Yeah, it's just she's bringing the punch. I think Leanne might have been bringing, I don't know, a cheese ball. I don't know. I can't really remember the specifics. Pam said pinwheels. Hey. Somebody said rotel dip. A fruit tray, a veggie tray, stuff like that. Just little yummy yummies. stuff like that. You know, a cheese ball.
want Denise's cupcakes.
Madam President Betty Crocker, we love you. Heather's like, you know, if it gets that bad, I'll buy the stuff as long as you'll cook it. So, I'll invite her for next Thursday.
Is this going to be after class?
This will be after the test.
After test?
Yes, after Lou's test. Well, after.
When my test will be, I don't know.
Yeah.
I would think it would have to be after lecture.
Yeah. Like,
So she's talking about after the OB test before lecture starts, like that in between time.
that in between downtime will trickle in
And triple tray.
and sit down, snack while we're in lecture, go back for seconds during lecture. No, I'm just kidding. But, you know, no.
How would I know what we want to bring?
Well, we had something on Facebook, but you told me you don't get on Facebook. So I guess we can pass around a list today.
Somebody just pass a piece of paper, sign what you're going to bring,
Yeah.
and give it to Vernisa.
All right, next Thursday. Woo!
Next Thursday.
Who doesn't care?
Next Thursday. Because y'all ain't having no bad November day, so y'all just heard my
No. The logic behind, let me explain, the logic behind November is there's 2 weeks in November and they've got testing them and then they were out for Thanksgiving that whole week. Well, when we come back, there's not going to be any time for any partying. We got Hessies like the first week of December coming back. So we're just going to do a whole
Like a big
Christmas
shindig.
happy birthday, yay! And we're done with finals. Or we can do the 1 October. Hello.
No, you don't count.
Yeah, I do. The one, yeah. It would be better to do. And we could do that October birthday, November birthdays, Halloween themed. Stay tuned for next month's announcement from your announcement girl. I don't know about dressing up. I do good to have on your face.
You can dress up for class.
30 something.
Oh,
my
what,
bad.
25.
I'm going to be a broke college student. I'm already dressed.
Alright. So, somebody send around a piece of paper, Heather, and get it to Vernisa before you leave. So we'll know who's having what.
Copy and paste and I type it in and then the critical I typed the one, but then yesterday, you know, I had so much time it's just worked out.
Alright, y'all ready?
Thank you for your time.
Alright, my last comment on pain management during labor is that it is what the patient says it is. Everybody's pain tolerance level is different. You could have somebody that's very stoic and does not express pain. You could have people that are very vocal but that manage their pain. And then you could have patients that come in 1 centimeter, not contracting, saying that everything is falling out and they want an epidural. So there's all kinds of people. Their tolerance to pain is very different. So you just have to go with the flow, and whatever they say it is what their pain is, okay? Remember we talked about last week, you're just going to document what you see and what they're saying. They're rating it a 10 and talking on the phone, and that's how you document it. Patient rates pain 10, but talking on the phone, no facial grimacing. Okay, and you will see labor and delivery nurses have a special relationship with their patients. So you will see some of them go, oh girl, yeah, you might want to save that 10, because you're going to need it later, because this ain't a 10. But that's not appropriate for the student to do, okay? Probably not appropriate for the nurse to do, but I have done it before. Alright, here we go. So that was stage 1 active phase. And we went ahead and talked about pain medication because that's usually when patients decide that they want pain medication. Now we're moving on to stage 1 transition phase. Contractions are strong and more frequent. Cervical dilation is 8 to 10 centimeters. If they have not already started to complain of pressure, they will complain of pressure at this point, or they may complain that the pressure is worse than it was. Nausea and vomiting are common during transition and active phase. Something about around 6 centimeters can sometimes cause nausea. So 1-6 is actually in the previous phase, 6 and 7, so just be aware of that. Mood changes, they become more anxious. This is where in the movies they like to yell and scream and cuss at their significant other for putting them in this situation. You will see some of that. And some of it's just more that they're just really anxious and don't know what to expect, so everybody just kind of gets barked at sometimes, and that's okay. Even if the epidural is in place, they're still going to feel that pressure. Encourage support person to assist patient if available. You don't always have a support person, but if you do, this is when you're going to want to get them actively involved. They need to be at the bedside talking with the patient if the patient wants them to talk to them. If they don't, then tell them to shut up. If they're going, breathe, honey, and she's like, if you tell me to breathe one more time, I'm going to kill you, then just say, why don't you just hold her hand? Or why don't you take this cool rag and just kind of dab her face? Because some people like to be talked through a contraction, other people do not. So wherever they're at, meet them where they are. All right.
I couldn't breathe their air in mine too. They were talking about
Yeah, and yeah, most people don't like people right up in their face. Under any circumstance, much less when they're hurting and they're hot and they're trying to have a baby. Anticipate delivery. At this point, if they're 10 centimeters, we're fixing to start pushing. Now, we don't push until they get to 10 centimeters, so once they're 10 centimeters, we can potentially start pushing. So we're going to get our equipment set up, so there may be a lot of activity going on in the room. It says contractions are strong and more frequent. Sometimes they are every 1 to 2 minutes and maybe lasting 60 to 90 seconds. Encourage the patient to breathe. No, they don't have to do Lamaze breathing and all that, but they do need to breathe for the baby. So they need, deep breaths when they're not contracting so that they're getting oxygen in for the baby. This is a good time to discuss pushing because they need to understand how to push. So how do we typically tell them to push? Like you're having a bowel movement. And usually I'll go so far as to say, when we start pushing, we're going to do 3 pushes that last 10 seconds each. So I'm going to count, and then you're going to take it. Like I'm going to count to 10, you're going to take a deep breath. I'm going to count to 10, you're going to take a deep breath. When you're pushing, you push the whole time I'm counting. And sometimes that's good, sometimes I don't want you to count. Sometimes I'll just look at you like, if you count one more time, then you just have to say, okay, we'll do it your way. So just kind of coach them on that. Okay. It also helps them to know that it is getting close, because sometimes we will tell them that and they'll be like, you've told me the last 5 times we're getting close. But when they're 10 centimeters, they can actually start doing something about it. They can start pushing. And sometimes that helps the anxiety because they're not just laying there waiting for the nurse to tell them what to do. They can actively participate in getting this baby out, which is sometimes a huge stress relief for them. So, but they do tend to be extremely irritable during this stage. Alright, so that was stage 1, latent, active, and transition. Make sure you know what happens at each stage. Now we're moving on to stage 2. Okay, all of the other ones were stage 1. Now we're in stage 2. It begins with complete dilation and it ends with the birth of the baby. So this is when they're pushing. From the time they're 10 centimeters to the time the baby comes out is your stage 2. There's usually a very strong urge to push. They may start to feel a sense of purpose because we're actually letting them push. They're doing something about it. May be irritable, frightened, or out of control. I'll just skip that one here. If they're irritable, you do try to calm them as much as possible without making them more irritable. If they're frightened, what do you think we do? Try to calm them down, tell them what to expect, because a lot of times them being frightened and irritable is just because they don't know what's coming next. They don't know what's going to happen. So usually, even when you're doing the little things, sitting at the nursery bed, telling the dad how to hold a leg, any of those things, you need to say it so that you know that she understands what you're doing. You're going to feel me touch down here. I'm going to put a blue drape up under you. I'm cleaning your perineum off. Okay? Once they get to this phase, of course, the physician's going to be notified. And depending on what station, he may come immediately in, or he may let you push for a little bit before he comes in. Just depends on what's going on with the patient. But what you'll see the nurses do is they're going to notify the physician. They're going to notify nursery, because nursery's going to need to come up and set up the bed so that they're ready for the baby. If their equipment's not already out, which it probably is, they're going to go ahead and get their equipment out. The patient gets placed in, some hospitals, they actually put them in lithotomy position where their legs are completely up in stirrups. Most of the time at our hospital, we don't do that. We just hold their legs, so we don't put them up in stirrups. You're going to need to drape the patient, so they get this, and if y'all have been in labor delivery, you've seen it. It's that blue drape that goes up under their hind end that has like a pocket that catches fluid and blood and all that stuff. It's got like a big pocket on it. We're going to then clean the perineum, and usually we do that with warm water and like a soapy sponge that you would scrub your hands with if you were scrubbing in to go to the nursery, or scrubbing in for surgery. We use the same ones. And then you're going to have the patient start pushing. She is, but she isn't. We usually try to keep her legs back, but we usually tend to hold the legs back. It is a lithotomy position, but it's not a textbook lithotomy where they're in stirrups. We're actually holding the leg as if they were in stirrups. But it gives the patient a little bit more freedom to move, and they can actually grab their legs. And that's usually what we tell them to do, is to kind of take their hand and grab their under their knee or behind their thigh, so that they can pull their legs back, because that opens the pelvis, but it also gives them something to pull against. So we usually usually it's a nurse and a family member that's holding a leg, one on each side. Okay? Just be mindful, if they've had an epidural and you're holding their legs, they don't have as much control over their legs, and they can actually move beyond their normal limits of what they could do because they don't feel it. It doesn't hurt. So don't be like letting their leg fall off the bed, because it could injure their leg and it could damage a nerve. And don't be like putting them in some kind of contortion position, because they're going to feel that tomorrow. They just don't feel it right now. So you just make sure that you keep them in alignment. You're not going to like force their leg out to the side where you're actually damaging that hip joint. So just hold it like you normally would. Okay. They will start pushing at this stage. Typically, we are charting on the baby about every 5 minutes. We talked about that. Depends on if they're high risk or low risk. But we do want to feel heart rate pretty often. And you're going to assess mom, how she's doing, that type thing. Usually. I mean, you may not do a full assessment, but you're going to be in there the whole time. This is not, the nurse doesn't leave. Once they reach this and they start pushing, the nurse will be at bedside until recovery starts. So you're there with them. So you're just going to document as often as you need to. The things that we do document about the baby, other than the heart rate, is we're going to document when there's a small crown, a moderate crown, when the baby's head delivers, when the baby delivers. All of those are important. The most important one's going to be what time the baby came out, because nursery's going to ask you, and you'll have to tell a specific time. So if it was 13:03, then that's what you say. 13:03, you look down, it's a baby girl, and the nursery will use that to figure out when they need to do their APGAR scoring, which we'll talk about in a little bit. Okay? So what is stage 2? It's really when you're pushing, but it's from 10 centimeters dilated to when the baby delivers. That's stage 2. Okay?
Now, I hate to go back, but going back to the epidural part,
Mm-hmm.
which stage is that? Is that the active or?
Whenever they get it. I mean, it could, most likely it's going to be active, because just like with the IV pain medication, there could potentially be a point when you couldn't get an epidural. For instance, if you're 10 centimeters dilated in a +2 station, If we sit you up, you're going to have a baby while we're sitting you up because you're going to force that baby out. But if you're 7 centimeters, a lot of times they'll do them, and some of them will do them when they're 9 centimeters. Just depends on the situation. So your epidural is going to be whenever the patient requests and or needs it, they can get it, as long as the physician's okay with that. No specific stage. Usually it's during active. That's why I put it there, because they're 4 to 7 centimeters. But it could be earlier. It could be later. Okay. All right. Is everybody good with that? Stage 2. All right. I put this in, so you may not have this, but and I don't know what I do with mine. This is all out of whack. I think my little girl got a hold of this because it's not really in order anymore. Alright, we'll just go with this. Episiotomy and lacerations. This is going to be done before the delivery of the baby. Lacerations are going to be tears to the perineum, where an episiotomy is going to be a cut that we actually made to provide a little bit more room for baby. There's a picture on there that shows a midline, which goes straight down, and then a medial lateral. It's going to go from kind of at an angle towards the side. And usually that's physician's preference as to which one they do. Most of them do midline incisions, but we did have, I don't know that we do now, but we did have a couple physicians that did medial lateral incisions, where they would actually cut from the middle out to the side. Okay. These can vary by degree, from 1st degree to 4th degree. So just be aware of that. What is a 4th degree? All the way. So it goes from opening to opening. So it actually goes through the rectal sphincter. So a 4th degree is not one that you want to have. And we don't typically, we have to do extra paperwork if a patient has a 4th degree episiotomy or laceration, because it is an extensive repair. So 4th degree is going to be all the way from opening to opening. 3rd degree is going to be from the vaginal opening, and it can be down to the rectal sphincter, but it's not through the rectal sphincter. By far, the most two that we normally do are 1st and 2nd degree. 1st degree is more of a superficial cut, where we just provided a little bit of extra room, and then 2nd degree is going to be slightly deeper than that. So those are the two most common, or your 1st and 2nd degree. 3rd degree can be down to the rectal sphincter, but not through it. And then 4th degree is opening to opening. 1st degree is more superficial, and then 2nd degree is going to be a little bit deeper than that, but it's not going to be down to the rectum. Okay. Alright, so what's the difference between a laceration and an episiotomy? Episiotomy is a surgical cut. Laceration is a tear. Which one do you think has more defined edges for repair? More straight edges? The episiotomy, okay? Now, you do have patients that come in and they don't want an episiotomy. They say, you know, if I'm going to tear, let me tear. And that's fine. The only disadvantage to a tear versus an episiotomy is that the episiotomy has straight edges, so it's often easier to reconnect. If they tear, it could be a jagged tear, so those are a little bit harder to repair. We don't always perform episiotomies. I would say we don't perform that many episiotomies. And you may have some superficial tears inside, like on the labia. Sometimes you'll get little lacerations there. That's not really a 1st or 2nd degree. That's just like what we call a little skid mark or a little tear when the baby came out. It's like an abrasion. So you can have some different ones, but these are the ones that are actually going to be from opening down. If you've got like a little tear up by the urethra, they may choose to put a little stitch in that because when they urinate, it's going to burn if it gets in that wound. So they may repair some little scrapes on the inside of the labia if they need to. But these are talking about true tears from opening down. Okay? Questions about that? So what type of pain management would they use if they were going to perform an episiotomy? Local. You'll just see them, they'll actually take a needle and inject in that area where they're going to cut.
How would
Lidocaine. Mediolateral. I think the thought process behind that is there's less stress on a lateral cut than straight down, and if you think about gravity and having a bowel movement, there would be more stress on that suture line if it's going from opening down than if it was from opening to the side. I think that's the thought process, but most of our physicians do cut straight down. It does tend to heal pretty well and pretty quickly. And they use dissolving sutures. If they're repairing an episiotomy, those are done with dissolving sutures so that hopefully they don't have to remove those because the area is going to be really tender. If they don't dissolve for some reason, they would have to be removed, but most of the time they use dissolving sutures. And it does heal pretty quickly. Okay? Alright, stage 3 is going to be delivery of the placenta. It begins with the delivery of the infant and ends with the delivery of the placenta. Mom is usually relieved and involved with the infant, and she may or may not notice that she's even getting rid of the placenta. Sometimes they will feel some pressure. Sometimes the physician will ask them to push down just a little bit, but it's not anything like delivering the baby. The placenta is not near as difficult to deliver as the baby, so they may not even realize it. It usually lasts between 5 to 15 minutes, so once the baby is out, then they're going to be in that time frame to look to where the placenta or when the placenta is going to come out. Usually after the baby comes out, if they were on Pitocin, the Pitocin will be turned off, because what you don't want to happen is you don't want the uterus to clamp down and hang on to the placenta. You want the placenta to come out, okay? So once the baby is delivered, if they're on Pitocin, the Pitocin needs to be turned off. Alright, I've got several different little tidbits here, so let me go through these. The patient may not remember the placental delivery. If a repair is needed, like if they performed an episiotomy or there was a laceration, they will typically do that repair after the placenta is expelled. You may need to assist them with that because they don't typically put sutures on the delivery setups. That will be done by physician preference, so he will tell you which needles and stuff he wants, and you'll actually pull those and put them on the table. You may have to adjust lighting so that he can see what he's doing a little bit better, so he may need you to hold a leg, but you may assist him in doing that. If the placenta does not deliver within 30 minutes, that's considered a retained placenta, and we may have to do a manual extraction of that, which is not wanted. So we're hoping that the placenta will detach on its own. Retained placenta. Now, of course, when they have a C-section, we do a manual extraction of that placenta anyway. But with a vaginal delivery, we hope that the placenta will detach on its own. Much easier for mom and baby. Or for mom. Usually if it's not delivered in 30 minutes, then you start to get worried. Some signs, if you're in the delivery room and you're waiting on the placenta, there's 3 cardinal signs that the placenta is fixing to deliver or that it's detaching. The visible cord that's outside the mom, because when the baby comes out, they clamp the cord and cut it so that baby can be taken to the newborn warmer to do assessment. But you still have cord hanging out that's attached to the placenta. The cord that you actually see outside the body will start to lengthen. It looks like it's getting longer because it is, because the placenta is moving down. Okay. There will be a gush of blood, so don't let that scare you, and that's because it detached from the wall, and there is some bleeding associated with that. And if you look closely at the abdomen, it'll usually change shape. So those are your 3 signs. The abdomen will change shape, there'll be a gush of blood, and the cord will start to lengthen. And what are the 2 ways that the placenta can come out? Fetal side and maternal side. The fetal side is shiny or beefy red? Shiny, and the maternal side is beefy red. What's the easiest way for it to come out? We like for it to fold in on itself and shiny side to be exposed. Okay. but it can come out either way. Shiny Schultz or dirty ducking. So the maternal side's kind of beefy and knotty looking, and the baby side's nice and smooth and has almost a translucent gray look to it. So if you get a chance in labor and delivery to see the placenta once it comes out, have them put their gloves on and show you where the baby was, because you can see the amniotic sac. Of course, there's a big hole in it where the baby came out, but you can see the sac, you can see where it was attached, and then you can see the maternal side. So make sure you look at that, because it kind of helps reiterate some of the stuff.
How does it matter which side?
Just that because of the knottiness of the maternal side, it's a lot more neat if it comes out with shiny side, because the dirty Duncan side is kind of enclosed on itself. Either way is fine, and you want to make sure that all of it comes out, but it's just a little bit less messy if it comes out with the fetal side. Okay. All right, if they're going to do cord blood, that would be done during this stage. It's usually done after the baby's cord has been clamped and cut and passed off. They will actually use the remainder of the cord that's attached to the placenta to obtain cord blood. And we usually obtain cord blood if mom is O positive or any negative, because they will use that to test and see if she needs to get RhoGAM. Okay. O positive or any negative blood type.
What do you mean by maintain cord blood over
There's a couple different ways you can do it, and it depends on the physician. Some of them just take a big needle and stick it into the cord and draw back the blood. Some of them actually take like a little sterile silver dish and unclamp the cord and let the blood run in there and then just suck it up in a syringe, so either one's fine. If they need cord blood, they will then pass that off. They will draw it up however method they want to, and they will pass it off to the primary nurse or to the scrub tech to put in a vial labeled with the baby's last name to pass to nursery. That's if they need cord blood. If they're doing cord blood banking, then that's a little bit different.
That's when you're donating the cord blood.
Or keeping it for yourself, yes. Yeah, some religions do want to carry their placenta home, and that has to be cleared. They have to sign it. Yes, we would still do cord blood and all that. We typically send the placentas to pathology to make sure there wasn't anything out of whack with them. Which is probably not a professional way to put that, but that everything looked okay. But if they want the placenta, then we can make arrangements for that. But it's not just going to stay in their room while they're there. They would have to sign and that kind of thing. Alright, if they were doing cord blood banking, we don't do a lot of that. I wish we probably did more. I think in the future it's probably going to be just standard practice to do that. But right now, the way it stands is if a patient wants to do cord blood banking, they bring their kit in. They order it and they bring the kit in. And the kit, and we don't do it that often, but the kit has specific instructions as to how things have to be drawn, which one has to be drawn first, and so the nurse would complete that kit, and it would be the patient's responsibility to have that shipped off, dry iced and shipped off to be banked. So that if they come in with a cord blood kit, this is the time that we would do that, and you would just have to follow the directions because each kit's a little bit different. So you would just get the directions out, and you would go step by step to get that. Because there's a lot of research now that the blood cells in the cord have a lot of beneficial uses for that patient in the future or for their family members. Like there's some research going on about spinal cord injuries and can that help repair the spinal cord, because those cells are not, they can do a lot of different things instead of being assigned to do one specific thing. So there's a lot of research in that, like your leukemias, all that stuff. So I think you're going to see a trend towards people doing that. It's going to be more routine. Right now, our hospital doesn't have a cord blood banking facility, so it has to be shipped to a place where they actually do it. Because you have to pay a monthly fee for them to keep it. Do you remember how much it was?
I remember it was a good bit. I mean,
Yeah.
for, new moms, that's a high
Right. Right. And I hope that we will see a trend to where it's cheaper and it can be housed locally. And I think you eventually will see that if it continues to be popular. Mhm. Yep. And I think last time we did, I think we had to draw. Seems like we drew 3 different vials of blood, and then we packaged them back in the container, and they dry iced them and shipped them. So, but we don't do it that much. All right. The perineum after this is going to be. It can be swollen, which is not abnormal. It can also be bruised looking because, I mean, even though it's a natural thing, it is somewhat traumatic to the tissue. So the perineum itself may be swollen, tender, and discolored, almost bruised looking. But it's important that you look at the perineum to see what it looks like now, because if you have a hematoma or something, you need to be able to pick out that it's different than it was. Okay? During the postpartum period, what type of discharge should they have while they're in the hospital? What does it look like? It's bloody. It's known as rubra. So the normal discharge after delivery is known as lochia, and there's several different types. But the one that you will see after delivery, immediately after delivery, is known as rubra. It's bloody. Okay? So lochia is just going to be that term that talks about the discharge after having a baby. In the beginning it's rubra and it's red, and then it's going to get pink tinged, and then it's going to get lighter, and we'll talk about those later. But the one in the postpartum period is rubra. Lochia is just that blanket term that talks about the different types of discharge after you have a baby. The first one is rubra. It is red. That's the reason it's called rubra. The lochia is just like a general term that talks about, because you don't just have rubra after you have a baby. You have other types of discharge, but immediately postpartum you're going to have rubra. And we'll talk about the other two when we talk about postpartum.
So it's like a category.
It's like a category, yes. Right. Your rubra can be small, moderate, large, copious. So there's a lot of different terms for the rubra afterwards, and those are going to be quantifiable terms. How much rubra are they having? Rubra, R-U-B-R-A. Copious, C-O-P-I-O-U-S, copious. Okay? Copious would be way too much. Copious just means it doesn't stop, it's continuous, and there's lots and lots of it. You can also see scant, which just means there's almost none. And then you've got small, moderate, large. Okay. What do you think you should have? Small to moderate. Moderate if they've had several babies, but small is typically what you want. A small amount of rubra, and you would prefer not to have any clots in it at all. But if you're having some clots, you want them to be really small. And remember we talked about in STEM Lab that small to me is probably not small to somebody else. When people say they're passing large clots, large to us is like the size of a dinner plate. Large to a patient is usually the size of a silver dollar. Okay? So that is relative. Small is going to be, what I usually tell my patients is they should not have any more bleeding than they would have with a normal period. But just like with a period, but you do have some people that have really heavy periods. So that being said, you may have to give them a little guideline. When they stand up, they may have a gush of blood. That's okay. Small, I think your book actually has a page where it gives you like centimeter measurements on a pad. We don't typically measure it that way. But small to me means that there may be a small area on that peri pad that may be saturated, like in the middle. But it is not saturated front to back. There's a small area. Scant's going to be like there's just a swipe of blood, almost like it hasn't even saturated into the pad. There's just a little superficial blood. And then when you get into moderate, that's going to mean that more of the pad's saturated. Large is going to be front to back. And then copious is going to be saturated and running over.
Would copious be like the pads that we used on that one lady?
The pink pad. If you go in and a pink pad is saturated, that is definitely copious. And that patient's hemorrhaging. Redheaded people do tend to bleed more. If they've had twins or triplets, they're going to bleed more because the uterus is going to have to work harder to clamp down and prevent it from bleeding. So your twins, triplets, or moms that have had several babies do tend to bleed more, so be aware of that. Okay? Your prima gravidas, if it's their first baby, first delivery, assuming there was no complications, their bleeding should be small after they deliver.
I know you document when the baby's born, but what about the placenta?
You document when the placenta delivers. Yes, you do.
You document the time and how, if it was...
We just document, we document the time, and we document if the physician said it was intact. So we document time, delivery of intact placenta per physician. He says it was all intact. Okay? Alright, let's see what else I can tell. Alright, we talked about that the Pitocin is turned off after what? After the baby's born. Once the placenta delivers, it's going to be turned back on, and it's going to be infused at bolus. Instead of being infused slowly to get them into labor, it's going to be infused at bolus. So as fast as we can get it in, or pretty fast. Usually we just infuse it as fast as it'll run. After the placenta's out. Then you start Pitocin. If they don't have an IV, then we give them IM Pitocin. It causes the uterus to clamp down, which is what you want now. Now that we've got everything out, we want it to clamp down hard because that's going to control your bleeding. Okay? So pit on at a slow rate that's gradually increased during labor. Pit stays on until baby delivers, assuming that you don't have D cells and have to turn it off. Stays on until baby delivers, it's turned off. When the placenta delivers, it's turned back on and it's infused at bolus. But we don't infuse pit at bolus while we're laboring, because if we did that, the baby would not like that at all. Okay? So gradually during labor, stays on until the baby delivers, it's turned off, goes back on after the placenta delivers. Alright, typically your lochia is small after the placenta delivers. If you've got a patient, let's see if I can figure out how to word this. If you're assessing your patient and you're trying to decide if the uterus is nice and clamped down, what is your assessment technique? What do you actually feel for? The fundus. And it should feel hard. And it should be located at least at the umbilicus or below. After delivery, the fundus should be no higher than the umbilicus. Okay? So let's assume that you've assessed that and your fundus is 2 finger breadths below the umbilicus and it's nice and hard, but you still have a constant trickle of blood coming out of the vagina. Do we have a problem? Potentially. And usually if you have a patient that has a constant trickle with a firm fundus that is 2 below, the culprit is usually a laceration up high. So if you are doing your assessment and you're like, okay, I'm still bleeding and everything's firm, then the physician may need to come back in and look to see if there's a higher laceration that he didn't see initially that's continuing to ooze. Because a constant trickle can be concerning. So don't assume that they've got to just be pouring blood out of the vagina to have a problem. That constant trickle can also be a problem. Okay? He would actually probably have to do a speculum, and if it's high enough, like sometimes the cervix can get a laceration, they bleed and bleed and bleed, and so he would have to actually probably put her in stirrups, do a speculum so he can see, repair it, stitch it. They do. Sometimes we have to hold. Sometimes they may put a speculum in to hold the tissue off. But with a baby, you just push the baby out through the cervix. So the cervix is not near as posterior as it would be in a non-pregnant patient. So the cervix is usually, it may still be open some. I mean, it's not going to be completely closed down. It's open enough that the drainage can come out of the uterus so that you can have the bleeding from that. But it's not going to be like 4 or 5 centimeters open usually. And the laceration that you're going to repair is not going to be stitching the cervix closed. It'll be stitching the edge of the cervix wherever that cut is, if that makes sense. You're not stitching it closed like a cerclage. You're just stitching the two little pieces together. No, because it's more, because you're not looking at the fundus, you're looking at the cervix, you're looking at the bottom part. So you just push the baby out. Technically, a lot of times it's very superficial, very anterior, so it's easier to get to. Okay?
I'm going to need to know the types of fundus contraction, or because in both, like chin, nose, forehead.
For strength, yes, but I'm not going to say, no, postpartum not. Just for laboring, you'll need to know that. And I don't really know a way to ask that question, because I'm not going to say, feel your patient's having contractions that feel like your nose. But you do need to know that earlier in labor, they should be more mild. When you hit active, they're usually more moderate. When you hit transition, they're usually strong. So you do need to know that. So each stage has a different type of contraction or strength of contraction, which makes sense because you want them to get stronger so that you can get the baby out. Okay? I may have to go back because I did find it. You have put it in here. I want to make sure I cover all this. Alright, if y'all will flip back to stage 2, let me just make sure I went through all this because I want to make sure that I've covered all my... We talked about the different degrees. Remember, stage 2 is going to be complete dilation to deliver the baby. So I'm just going to go back through this and make sure that I have covered it all. I think we pretty much did, but just in case. Alright, no pushing until there's 10 centimeters. I think we touched on that because if they push before that, it's going to cause their cervix to swell, which can cause problems. So no pushing till they're 10. We've talked about that you're going to need a temperature on mom. Remember we talked about doing a maternal assessment. Make sure you get a temperature pretty close to delivery because nursery is going to ask you what the temperature is. Because if mom's running a fever, then baby's probably going to be running a fever. So make sure you get a maternal temp pretty close to the time that she delivers because nursery's going to ask you about it. We talked about documenting a small crown, a moderate crown, delivery of head, baby, and placenta. Placenta's on the next stage. But we talked about last pain medication. The other thing that I did not mention was if the patient was group B strep positive, you need to let the nursery know how many doses of medication they received. So if they received 2 doses of penicillin, then you need to tell nursery that. In order for them not to have to run tests on the baby, they have to get 2 full doses of medication in. And usually it's every 4 hours that we give that. So you could potentially have somebody that could have 4 or 5 doses if they had a long labor, or you could have somebody that had a really quick labor that only got 1 dose in. So if they were GBS positive, let the nursery know how many doses of antibiotic they got. Okay. And what is GBS? Group beta strep. Remember we talked about that when they first come in. We're going to look to see if they're group beta strep positive. What is group beta strep? It's a normal flora for a lot of women. So why do we treat them for it? Because it can be harmful to the baby. It's not going to cause any problems for mom, but it can cause problems for baby. Good. Group beta strep? It could be. Or it could just be an acquired normal flora for you, but you could be born with it. probably not immediately born with it, but as as your flora progresses or whatever, that you would have it. Because usually you don't have it right at birth. Let's see, we talked about that. I was going to talk about meconium. We talk about augmentations of labor and breaking water and that type thing. But what is meconium? It's the first stool. So if they have their first stool in utero, when the water ruptures or when the water's broken, they'll have what we know called meconium-stained fluid, meaning there's been a bowel movement in there. So it's usually green tinged, or it can be really green like split pea soup. Just depends on the level of meconium that they have. But your nursery is also going to need to know if their fluid was meconium stained. Because what we used to do is we used to suction the baby. Like when the baby's head came out, we would actually suction the baby on the perineum to see if we could get meconium out. You don't see that used as much, but if you see the terminology of DeLee suctioning, D-E-L-E-E, that's just suctioning them on the perineum. And it's not like taking the bulb syringe and cleaning their mouth and nose. It's suctioning them, like taking a little suction catheter and putting it down their nose to try to get all that meconium out. You don't see that used as much. What they will sometimes do is once the baby delivers, instead of stimulating the baby like we normally would, trying to rub the baby to get it to start crying, they'll take it immediately to the nursery warmer and suction it before they stimulate the baby. The thought process is there, once that baby takes that first deep cry, where does that meconium go? In the lung. So they may even take a, not a tongue blade, I forget what the thing's called, okay, somebody help me out. The thing they actually do the intubation with, the metal thing, stylus. They may take that and actually look at the vocal cords and suction out before they stimulate the baby. So if you see that, we usually do some type of suctioning if they're thick meconium. Okay? Whether we do it when the baby's head comes out, when the baby gets to the warmer, or if we actually do endotracheal, where we actually put this, look like we're going to intubate them, suction out, and then stimulate them. Okay? If they notice when they do that exam, when they take that stylus and they look at the vocal cords and look at the trachea, if they notice that there's meconium down in there, they will usually do a sepsis workup on that baby because there's meconium low in their system. Okay? I don't think I told you how long second stage lasted or can last. It can last up to 2 hours, but 2 hours of pushing is a long time. So if you reach that hour of pushing mark and we're still not making a lot of progress, one of two things is probably happening. Either mom's not pushing effectively and she's exhausted, or baby's not fitting well. So prolonged periods of pushing are not usually recommended. So if they've been pushing for 2 hours and baby's not making any progress, they may look at other delivery methods. 2 hours is usually max on pushing. If the baby's not descending, like if you pushed hard for 2 hours and the baby's not moving, there's a reason the baby's not coming down. Okay. We did talk about pushing and the 1 to 10 method and the three different pushes during a contraction. That's by far usually the method that we will use, is we will do the 3 pushes with each contraction. You can do different positions. You will see some people that will push in all 4s, although it's not usually a position that we do unless we have to. If the baby's not tolerating pushing very well, sometimes all 4s is a way that you can give them a different angle, take some of the pressure off the baby. You will also see some of the nurses do a push-pull method where they actually take a towel and give the towel to the patient, and they hold on to the towel and the patient tries to pull them into bed with them, because that's a different way to sometimes get them to push in the right spot. You'll see them sometimes use a bar on the side of the bed where they can actually pull the bar to push. So there's a lot of different methods that we can use to help them push. By far, the one that we use most often is just 3 pushes per contraction, deep breath in between each 10 seconds. push for 10 seconds, breath, push for 10 seconds. Okay? And you may have to try every one of them to find which one works for the patient. If they're still not pushing well, you may even see the physician use something known as a vacuum. How many of y'all have gotten to see that when you went to labor and delivery? You might get to see a vacuum delivery. It's called, the name brand that we use is Kiwi, but it's a little vacuum that goes on the baby's head, and they actually pump it up to apply pressure, and when mom pushes, they pull down on that vacuum to help mom get baby through the pelvis if they're really tired. Yes. In the surgery? Probably. It was a little round white thing, had a little white cord and a little hand pump. Yeah. Yeah. Yeah, and it sometimes will pop off. And I want y'all to think about what happens. If you've got a suction cup attached to a baby's head and it pops off, they're going to have what looks like a big old hickey on their head. Because it's the same principle. So those babies can have bruised heads from the vacuum. And we try not to use a vacuum. If we can help it, we don't typically use those. But that baby's heart rate was ka-thunk, ka-thunk, ka-thunk. So we're like, okay, got to help that baby get out. So, but you will see that. I put a note on here. There is a pressure point on the bottom of the foot that can sometimes be helpful in relaxing the patient. So if they are, and sometimes when they're pushing, they can get out of control. So if they're really, really anxious or kind of out of control and they're trying to squeeze their legs together instead of open their legs up, it's actually it's midway, like if this is the foot and these are the toes, up under there, kind of in the middle of the foot, there's a pressure point. And if you're holding a leg, your hand is just perfect to take your thumb and massage that pressure point. And you'll be surprised, it can be effective for patients. So there is a pressure point on the bottom of the foot that helps them calm down. And if you're holding a leg, you're at perfect opportunity to do it because your finger's right there anyway. So even if it just makes you feel better. I don't know. But it works. Alright. Alright, this is just kind of FYI. During the second stage, make sure that the bladder is empty, because if it's not, the baby may have trouble descending. If they've had an epidural, they should have a catheter in anyway. And we usually take the catheter out when they start pushing. But if they have not emptied their bladder, then you may need to do a straight cath to make sure that their bladder is nice and empty, because it can hinder the baby from descending. How many of y'all actually got to see a vaginal delivery that went to West Georgia? Okay. What does the perineum look like when the baby comes down? Even before they start crowning, what does it look like? It's real, it bulges. So if you ever see the perineum start to bulge or the rectum start to bulge, then that baby's head's putting a lot of pressure down there. So a lot of times you'll see that bloody show, that mucousy blood from where the cervix is dilated, but you'll also see rectal or perineal bulging. And I think your book has a picture. Yeah, it's pretty graphic. Probably not a book you need to let your kids get their hands on. Yeah. They were like, oh no. One day. Might scar them for life. Alright. Now I'm going to move back. Sorry, y'all. Move back to where we were. And I think I finished stage 3. So we're going to move on to stage 4. There's your placenta delivery. The top one would be what? How's that placenta coming out? Shiny Schultz or Dirty Duncan? Shiny Schultz. And the bottom one's coming out? Dirty Duncan. And after the placenta comes out, you're going to do what? What medication is going to go in? Pitocin at bolus. If they don't have an IV, then a lot of times we'll give them IM Pitocin. We'll give them a shot. Okay. Alright, stage 4 is recovery. The pulse tends to increase, the blood pressure tends to decrease. They may experience a shaking chill, and they may or may not be cold, but they may be shaking like they are. So if you ask them, a lot of times they'll say, no, I'm not cold, I just can't stop shaking. That's completely normal, and they should be told that it's completely normal. Otherwise, it makes them think something's going wrong. But with the changes in fluids and the hormone changes that happens right after delivery, they tend to get this really weird shake, and that's okay. If they had an epidural, it's usually worse. Okay? Alright, urine may be retained, so if they had to push for an extended period of time, like let's say that you cathed them and they pushed for 2 hours and now they're postpartum, then you may have to do another straight cath on them or see if you can let them void. They may be thirsty and hungry because, one, we didn't let them eat during labor and they've done all this work, so they're usually at least thirsty if not hungry. Okay? Why do you think the pulse and the blood pressure changes? Okay, with any delivery, regardless of how textbook it is, you're going to have some blood loss, right? So your vital signs changes are usually because of that fluid shift and that blood loss. Even though you may not be anemic from that blood loss, your body's going to perceive that 300 cc blood loss or 500 cc blood loss as a loss. So it's going to compensate for that. Alright, nursing care is going to revolve around providing peri-care and bonding to the baby because the baby's usually still in the room, having its little newborn assessment done, APGAR scoring and that type thing. Perineal care is going to be pretty self-sufficient. You're going to make sure that the perineum is not bleeding profusely. There could be some swelling. This will be done, of course, after the physician completes his repair. But once you've done that, once he's finished, you're going to clean the perineum, and usually we do it with warm water. We make sure everything's nice and clean. We're going to put an ice pack to the perineum so that it will help with swelling and pain. We're going to check the bleeding. We're going to check the fundus to make sure that it is firm and below the belly button, at or below the belly button. If it's to the right of the belly button, what might be going on? Urinary retention is usually. If it is to the right and your bleeding is heavier, it's usually because you've got a full bladder. Okay? Good. Put an ice pack. We usually put an ice pack on the perineum. Just be careful with that. With some of your cultures, you may want to just ask them if they want an ice pack to the perineum because some of them may not. Most of the time we put an ice pack on the perineum though. If they are choosing to breastfeed, we typically advise them to breastfeed during this time. Can anybody think of why? There's two reasons. One's about the mama and one's about the baby. Okay? If the baby breastfeeds, remember we talked about nipple stimulation can be used to cause contractions? What do you think the baby does when it breastfeeds? So it causes the body to release the natural oxytocin, which causes the uterus to clamp down, which decreases your bleeding. So that benefits mom to breastfeed because it actually clamps the uterus down. Now, is that going to cause her to have some pain? It may, and that's what's called after pains. It's where the uterus is contracting down. It causes that crampy pain. But it's good that it is clamping because it's going to decrease the bleeding. So breastfeeding in that immediate postpartum period helps mom by decreasing the bleeding, but it also helps baby because baby's more alert during that period. So they're nice and awake, and there's going to be a point after that when, like mom, they're going to need a nap. So that first hour postpartum is very important if they're going to breastfeed to go ahead and try to get them to breastfeed because the baby's more awake. Okay? Alright, when we're doing peri-care, how do we do peri-care? I know this sounds like common sense stuff, but it's a good test question. How do we clean the perineum? In which direction? Front to back, just like they would wipe. So you're going to make sure that when you're cleaning the perineum off, that you're not rubbing back to front, because what are you doing? You can contaminate the area and cause infection. Good.
They just poured a bottle of penicillin, I guess.
Mm-hmm.
I mean, that kind of freaked me out. Because they just, I mean, it was like, they got their hands like this,
Mm-hmm.
all over her. And of course, he didn't know it. But
Right.
I was that shocked when they did.
And usually we'll pour some and then we'll kind of clean them off and then we'll rinse them again.
Yeah.
But we still pour from where it runs front to back.
From the top
Yeah.
to the bottom. But I mean, it was just like, shocked.
Douse them. Alright, vital signs, just like any other procedure, are going to be Q15 times 4, Q30 times 2, Q1 hour times 2, Q4 hours. I'm going to go back. Q15 times 4 should get you through your recovery in labor and delivery. So Q15 times 4, that's an hour. Then Q30 times 2, so that's your second hour. Q1 hour times 2 gets you 4 hours postpartum, and then it goes to Q4 hours. So Q15 times 4, Q30 times 2, Q1 hour times 2, and then it's every 4 hours. Why do you think we watch their vital signs so closely that early postpartum period? Bleeding. Because if they start to bleed, hopefully you'd pick it up because you're going to see the bleeding, but they could potentially have a hematoma that's inside that you don't see that could cause changes to their vital signs. So very important. Alright, this is from placenta delivery until your 4 hours postpartum is actually considered your immediate recovery period. This immediate recovery period is considered from delivery of the placenta for about 4 hours postpartum. Okay, let's say that we're in this period and we're back in, yes. Stage 4 is actually placenta delivery until 4 hours postpartum. Or through 4 hours postpartum, however you want to look at it. During this period, this is when we're getting everything completed back there. But could they have some bleeding problems during the first hour? Absolutely. So I want to kind of go over medications that you may see used if something happens and the Pitocin doesn't stop the bleeding. And it's not going to completely stop it, but if it doesn't decrease the bleeding to an acceptable amount. Because we said how much is normal? How much rubra is normal? Small, moderate is the top you want to be. So most of the time it's small. So let's go through these. I'm just going to list them for you. Hemabate. Hemabate is usually given for C-section patients that the uterus is not clamping down while they're in the OR. It can be given IM, but it's typically given intramuscularly directly into the uterus. So obviously you'd have to be on a C-section. Okay? So Hemabate can be given IM, but usually if we're using Hemabate, it's used during a C-section and it's injected by the physician directly into the uterine muscle. Okay, Hemabate. That's really all I want you to know about Hemabate. Yes. Yes, you can, but we typically usually it's used for C-sections. But yes, it can be given IM. A lot of times it's just given intrauterine into the muscle of the uterus. Help stop bleeding. So the Hemabate will cause the uterus to contract down, and that's what it's meant to do, is to help control the bleeding. Okay. We already talked about Pitocin. After the placenta's out, your Pitocin is bolused, usually at least half a bag or so, and then they will decrease the amount that they're getting. But Pitocin is by far the most common one that we use. Does anybody know what some of the side effects of Pitocin are? We're going to talk about it as an induction drug in a little bit, so we'll cover all that. But does anybody, when they did their medication sheet, know what it causes? Water retention. Water retention. So that's why the next day after an induction they look like a Stay Puft Marshmallow Man. I don't know why they're so swollen. It's because they have Pitocin all day. So. Alright, the other one is Methergine. Methergine. The dose is usually 0.2 milligrams. It is an IM injection. It helps contract the uterus, which is why we give it, but it cannot be given in the presence of hypertension because it will worsen the hypertension. So which patients should not get Metrogen if they have bleeding problems? Your preeclamptic patients. So Metrogen should not be given in the presence of hypertension because it will worsen the condition. You will also see a drug called Cytotec given. Cytotec, I think is how it's spelled. Cytotec. If Cytotec is given for bleeding, it is given per rectum. So you actually inject the tablets and you put them into the rectum to control bleeding. It can also be used for other things, which we'll talk about in a little bit. But if you're given Cytotec for bleeding, I think the dose is usually 800 micrograms per rectum. Bleeding. Okay, so let me just go back through these. Hemabate, given IM, it's most often used in the operating room, and it's usually injected by the physician directly into the uterine muscle to help the uterus clamp down. Metrogen, IM injection, 0.2 milligrams. Do not give it if the patient is hypertensive. Pitocin, given in a bolus dose after the placenta, because remember, none of these are given before the placenta delivers, because if you do, you can trap the placenta in there, okay? Cytotec, 800 micrograms per rectum, and it's just a tablet or a couple tablets, depending on how they dose it, that goes into the rectum. Okay.
If you get a C-section patient, they're not going to get Pitocin, they're going to get the Hemabate, or do they give Pitocin a chance?
Usually they will give the Pitocin a chance. Pitocin's going to be your first line, and even with a C-section, they get bolus Pitocin once we get the placenta out. If the Pitocin is ineffective, then they would move on to some of these others. And if they were in a C-section, typically they would use Hemabate, because the patient's draped. Getting to a muscle is going to be hard with the patient draped. Hemabate, they can just put on the table and give it straight into the uterus so that it works faster. Okay? But Pitocin will be your first line. The other three, Hemabate, Metrogen, or Cytotec, will not be used unless the Pitocin is ineffective. Or for some reason they couldn't give Pitocin. Okay? Alright, in this recovery period, we talked about how often you'll do vital signs. You're also going to check the fundus every 15 minutes, and it should be firm, at or below the umbilicus, and midline. It should not be deviated to the right. Every time you do a vital signs check, you do it. So that Q15, Q30, Q1 hour, you're going to do all of these things, okay? So you're going to do vital signs, you're going to check your fundus, firm, at or below the umbilicus, midline, not deviated to the right, okay? You're going to check your bleeding. Should be small, no more than moderate, rubra, which is red, and you would like to see no clots, okay? Your episiotomy, if they had an episiotomy, then you're going to look at that to make sure it's not swollen, there's not any hematoma or bruise that's forming around it, because your hematoma, even though the whole perineum may look dark, like a deep red because it's been traumatized a little bit, a hematoma is usually going to be one-sided. You'll see it kind of bulge out, so it's going to look more like when an IV infiltrates and it bumps up, it kind of has that appearance to it, except for it looks bruised. Okay? You're going to look at the perineum to see if there's swelling, and generalized swelling is not abnormal, and our intervention for that is an ice pack, so we put an ice pack on them. You're also going to assess bonding if the baby's still in the room. Is mom holding the baby? Is she breastfeeding? Does she need help with breastfeeding? Is the dad involved? Is there family in the room? All of those things. Especially if they had an epidural, or if we're talking about a C-section of spinal, you're going to look at movement and sensation. Can they move their legs? Do they feel normal to them? And don't forget about your bladder. Because if your bladder gets full, it's going to cause your uterus not to be able to contract down. Your bleeding is going to get heavier. So if you go in to do your fundal check and you find that the fundus is now above the umbilicus and deviated to the right, your nursing intervention is going to be empty the bladder and then reassess the bleeding. Okay? All right, let's talk about induction of labor. All right, you do get a card, remember, on this test. You get one index card, front side only, 3x5, that you can bring to this test because there's a lot of information on it. But the large portion of that is going to be your stages of labor and what's going to happen at each stage, right? So if you can, that's a large chunk of this test. All right, induction of labor. It's the use of chemicals or mechanical modalities to initiate uterine contractions. Considered if maternal or fetal condition exists, it requires delivery. It requires more intervention, is basically what that means. It requires a lot more hands-on care. There are some very good reasons why we induce patients, and there's some not so good reasons why we induce patients, okay? There's a reason that the due date is 40 weeks. That's because when the body's ready to have a baby. When you start inducing people prior to that, then you can run the risk of their body not being ready, and therefore they may end up with a C-section. So that's the downside to having an induction. But there are some very good reasons why we need to do an induction. What is a post-term baby or post-term pregnancy? It's after 40 weeks. Okay. Maternal medical conditions. Something's wrong with mama and we need to get the baby out. Okay? Yes, could be. That was the next one on here. Could be preeclampsia. It could be heart problems with mom where they want to induce to make sure that they have a more controlled environment. Preeclampsia is probably the reason we do most of our medical induced inductions or medical reasoned inductions. Fetal demise, which would be what? Death of the fetus after 20 weeks, because before that that would be considered a miscarriage. So this is where we're actually going to have to induce labor for her to expel the baby. Chorioamnionitis, any idea what that is? It's an inflammation or infection of the amniotic sac. And a lot of times that will happen if they are dilated for an extended period of time. They can get chorio. No, that's just going to be meconium if they had a bowel movement inside. Now, if they had a bowel movement inside and the lining got an infection, then yes, but usually the GI tract of the baby's sterile, so it shouldn't really cause an infection. Prolonged rupture of membranes. The longer they're ruptured, the more likely they are to get an infection, because that bag of waters was the last resort to keeping that baby free of infection. Because the other things would be what? The mucus plug, the closed cervix, the pH of the vagina. But now, if they're dilated and now they're ruptured, that was their last line of defense. It's also the reason that we don't check them any more than we have to after their water's been broke, because it increases their risk of infection. And fetal compromise. If there's something going on with the baby, that's going to require them to go ahead and be delivered. Now, if the baby's having a massive decel, we're not going to choose induction as our delivery method. What's going to be your delivery method? C-section. But if there's something going on with the baby, let's say, for instance, you had a mom whose baby had gastroschisis, which is where the intestines are on the outside, that would be a C-section delivery. But if you had a baby with, let's say, a known heart problem that could deliver vaginally and then be transferred or be taken care of, then they may choose to induce that patient versus having a mom come in 8 centimeters and not a controlled environment. Okay? All right, the induction rate has increased by 125% since 1989, which does not shock me at all. Everybody wants to have their babies. 125% by 1989, or since 1989. people want to have their babies. They don't want to wait till 40 weeks. They want to see their babies at 37 weeks. But that's not really the best case scenario. Guess which population group has the highest rate of inductions? Caucasians. Guess who has the lowest risk or incidence? Hispanics. Okay. Caucasians have the highest induction rate, and Hispanics have the lowest, because Hispanic patients see pregnancy and labor as a natural occurrence and not something that needs to be meddled with for the most part. So we have very few Hispanic patients that are actually going in for inductions. Okay. All right, induction does carry some risk. The more successful, or the more likely that it is to be successful, is going to be determined by how ready the body is. And you'll see here this, it says, is the cervix favorable? And I know that sounds kind of a weird term, is it favorable for labor? But there's certain feels and things that we can address to see if the cervix is actually ready for labor. The Bishop score is typically what we use to determine this, and you don't have to be real proficient, but I am going to give you a little information about it. The Bishop score is going to be a 0 to 3 scale, and you're given certain points for each thing, but it looks at the position of the cervix. So, which one do you think is more favorable for labor? One that is anterior or posterior? Anterior. Because a lot of times early in pregnancy, the cervix is extremely posterior, so it's kind of back. But as it moves around, the body's kind of preparing for labor. So you want your cervix to be anterior. Consistency. Firm or soft? Which one do you think is better? Soft. So the softer your cervix, the better. And sometimes you'll hear the labor and delivery nurses say, I don't think she's in labor. It doesn't feel like a laboring cervix. It's posterior. It's not soft. Okay? So a soft cervix is preferred. Effacement. Obviously, it's better that it's effaced than not effaced. Dilation. Better that it's dilated than non-dilated. That one's kind of... And then fetal station. The lower the fetal head is, the more likely that your induction will be successful. So each one of these areas is given a score. If they score less than 6, then they usually want to use some type of cervical ripening agent to help ready their body for labor. And we're going to talk about those in a little bit. So the lower the Bishop score, the more likely they're going to need some extra help to put them into labor. Yes?
I thought you said it was 0 to 3 scale.
Each item gets a score of 0 to 3.
You know, what's the top item?
The top item?
What can you get?
Less than 6 is what you need to worry about. Because some of them are ranked 0 to 2, some of them are ranked 0 to 3, and I won't ask y'all to do that. Just know that less than 6, they're going to need some type of cervical ripening agent. Okay. Alright, points are given for each one of these, and then you're going to look at your total points and decide what your plan of care is. Okay? So, here we go. Alright, for your cervical ripening agents, Cytotec needs to be marked off. We don't use it as a cervical ripening agent anymore. We don't use Cytotec a lot anyway, but just kind of mark that one off. Cervidil is the one that we typically use. It's a prostaglandin, and it helps ready the cervix for labor. And it looks like a flat tampon. And what they do is they actually bring that patient in the night before they're going to do the true induction, and they, where their cervix is, so if this is the cervix, they take this flat tampon and they put it right up under the cervix. And so it slowly releases those prostaglandins into the cervix in hopes that it will soften the cervix and get it ready for the Pitocin that they're going to give the next day. So that's going to be your Cervidil. Cervidil. Okay. Cytotec I am going to mention here. You will see it used sometimes as an induction agent. It's not used as a cervical ripening agent anymore because it's more associated with hyperstimulation. Which, what was hyperstimulation? too many contractions too fast. Okay? So we don't really use it for that. If by some chance they're using Cytotec as their induction drug, oxytocin cannot, or Pitocin cannot be started within 4 hours of them receiving the Cytotec. Okay? So if they're going to use Cytotec as an induction drug, then it's tablets, it's placed in the vaginal fornix, so up around the cervix, kind of like the Cervidil, and they cannot have Pitocin for at least 4 hours after they've had Cytotec. The reason that they're kind of leery of Cytotec is because a lot of times it will cause that hyperstimulation where they just contract, and they're not getting any rest in between. So, but what was the other use that we said we could use Cytotec for? To control bleeding. But where do we give it if we're controlling bleeding? In the rectum, and it's a much higher dose. Okay? So Cytotec can be used for induction, or it can be used to control bleeding postpartum. Alright, with the Cervidil, usually the Cervidil stays in place for at least 5 to 7 hours. So they'll come in at like 6 o'clock. We'll get them all set up, put the Cervidil in, take it out first thing in the morning, let them shower, and then usually your Pitocin can be started 30 to 60 minutes after the Cervidil is removed. And when I say it looks like a flat tampon, it has a string like a tampon, so it's just removed. Okay? And then you can start your Pitocin usually 30 to 60 minutes after that. So that gives them enough time to get up and shower and get back in the bed, and you'll start the Pitocin.
You said 4 to 6 hours?
Do what now?
4 to 6 hours?
Stays in place 5 to 7 or somewhere around there. And then they can start Pitocin 30 to 60 minutes after it's removed. The Cytotec may have been what you were thinking about, Pam. You can't start Pitocin within 4 hours after they've received Cytotec. I don't know if that's maybe that's what you're talking about. Alright, some reasons that we would not do this. If the baby's heart rate's not reassuring, if the mom has a fever or has an active infection or a history of a C-section, you will not see Cytotec used for a C-section patient if they're VBAC, and Cytotec is not the one that you're going to use. And even though these are meant to be cervical ripening agents, they could potentially put the patient into labor, so you do have to monitor them closely to make sure that they're not going into labor. Which is not a bad thing. If the Cervidil puts them into labor, great, but it usually doesn't, but just make sure you're watching them. Alright, so Cytotec, do we use it as a cervical ripening agent? No. It can be used as an induction agent, okay? Alright, some mechanical methods that you may see used to help induce a patient. Stripping of membranes. It hurts. Usually when patients come in and have had their membranes stripped, they usually describe it as the most painful vaginal exam they've ever had, because what they actually do is try to separate the membranes from the lining of the uterus, because that's going to stimulate the body to produce prostaglandins and hopefully put them into labor. It's called stripping the membranes. And sometimes they will do that if a patient's really wanting to go into labor. The physician will do that if they're term, of course. They're not going to do it if they're preterm, but they actually do a vaginal exam, and they kind of rigorously try to separate, they strip them. They just kind of separate things to kind of get prostaglandins going and hopefully throw them into labor. Balloon catheter I put on here, we don't use it very much, but it's kind of an interesting idea. But basically what they do is they take a Foley catheter balloon and they blow the balloon up, and they put it through the cervix, they blow the balloon up, and they put traction on it, so they keep it where the balloon is pretty tight against the cervix. And when it falls out, they know they're 3 to 4 centimeters. Because that's about the diameter of the balloon, is 3 to 4 centimeters. So they apply pressure, they put it through it where it's not blown up, they blow the balloon up, they put a little traction on it to keep the pressure on the cervix. When the cervix dilates and the balloon catheter falls out, you know they're at least 3 to 4 centimeters. Okay? By far, the most common thing that we use is oxytocin. But before we cover that, I want to just make sure that you understand what we're doing here. The cervical ripening agents that we talked about are going to be used to help ready the body. So the one that we talked about was Cervidil, correct? So what they do is they come in the night before, they get their Cervidil, they stay with us all night with the Cervidil in place. They get up in the morning, we take the Cervidil out, they shower, we put them back in the bed, and now we're going to induce them with oxytocin. So we had the cervical ripening agent to get everything ready, and now we're going to start them on Pitocin. The Cytotec would just be used as a induction agent. Okay. All right, oxytocin. It's a hormone produced by the pituitary gland to help stimulate uterine contractions. It can be used to induce or augment labor, and we're going to talk about that in just a minute. It has to be on an IV pump. Has to be on an IV pump. The dose is increased every 15 to 30 minutes until a contraction pattern is reached. So this is a drug that is titrated for effect, meaning that we increase the dose to get them in a good contraction pattern. And we usually increase the dose every 15 to 30 minutes. And we increase it by 1 milliunit or 2 milliunits. 1 milliunit every 15 minutes or 2 milliunits every 30 minutes. Okay? So it's titrated to effect. We usually increase it by 1 milliunit per minute, Q15 minutes. Like if it's on 1 milliunit now, 15 minutes from now, increase it to 2 milliunits. Or you can go up by 2 milliunits if you're doing it every 30 minutes, which is basically the same thing. Typically, the max dose that we will put a patient on without any internal monitors is 20 milliunits per minute. So if we're increasing it every 15 minutes, once we reach 20 milliunits, then we have to reevaluate and see what's going on. It's actually measured per minute, but don't let that confuse you. It's just 20 milliunits. Okay?
You said it without a monitor?
Without internal monitors. Because you're going to have these patients have to be on a continuous monitor. But with internal monitors, you can go up higher. Without them, you have to be at 20. Okay? Alright, you do need to make, well, I'll talk about that in a minute. You do need a baseline assessment on mom and baby. And baby is evaluated every time you go up on the Pitocin. So usually you are evaluating mom and baby every 15 minutes. So baseline assessment on mom and baby, and then they're reassessed every 15 to 30 minutes depending on how you're increasing your Pitocin. So every time you go in that patient's room to increase the Pitocin, you evaluate mom and baby. And it says monitor for hyperstimulation. What does that mean? Too many contractions or too long contractions. Basically, baby's not getting any resting period in between them. So this could be contractions that last greater than 90 seconds or contractions that are too close together. And what do you think happens to baby if there's not any resting time in between the contractions? How are you going to know the baby's not happy? They'll start having D cells. Okay. And hopefully you don't wait till you've got the D cells to do something about it. Okay. Alright, as far as oxytocin goes, we talked about how it's delivered. We also talked about when you would stop it, when you would start it back, that type thing. One of the biggest side effects with oxytocin is going to be that water retention. So hyperstimulation and water retention are going to be the two side effects that you're going to need to watch for. And usually we don't see the water retention as much when we're given it. It's usually the day later when they wake up the next morning they're swollen because they've had the oxytocin. So hyperstimulation and water retention are big with your oxytocin. Or really long contractions. It's just not giving the baby any rest period in between. So it can be really frequent or really long contractions. Just depends. Alright, augmentation. Oh, I'm sorry, go ahead.
You said that you do a baseline every 15 minutes every time you increase
Every time.
oxytocin?
Or even if you're not increasing it, every time you could potentially increase it, you're going to assess them. So basically, you're going in the patient's room and assessing mom and baby every 15 minutes is what it boils down to.
When you say oxytocin, is the hormone produced by the body, but what you're actually injecting is the pill.
Right, synthetic oxytocin, yeah. Oxytocin, true oxytocin is what the body produces. Pitocin is what the synthetic form of oxytocin. Okay. Alright, augmentation is the stimulation of uterine contractions after labor has begun. So if they get there and their contractions are not what we need them to be, or we need to speed their contractions up, there are some things that we can do to help speed up labor, or to help it along. And one of those is an amniotomy, which is not done by the nurse, it's done by the physician, but it's basically breaking the water. Amniotomy. Typically, we will use one of the two pictures that are on there. The first one is an amnicot, which is like a little condom thing that goes over the physician's fingers, and on the end of it, it has a little tack where they can actually do a cervical exam and snag the bag of waters that way. That's usually used if they're not dilated very much and they're wanting to break their water. They'll use an amnicot. So they just put that over their sterile glove. It has a little tack on the end of it. They do their vaginal exam and they kind of snag the bag of water, and it'll cause rupture of membranes. Okay. The one on the right hand side is an amni hook, and it looks like a crochet hook. So they would do a vaginal exam, and with their other hand that's not within the vagina, they would actually insert the hook and kind of snag back a little bit, and it would puncture the bag of water, causing the water to be broke. If they're not dilated very much, it can be painful. If they're dilated, it just feels like a lot of pressure. So it depends. Yeah. It's usually very uncomfortable because they're having to manipulate more than they would be just if they were doing a vaginal exam. A lot of times I guess that's relative to the patient. And if they're not very dilated, it is painful because they're trying to maneuver things around in a very small area. So we'll go with it can be. How about that? All that for it can be, but whatever. Alright, you do need to make sure that if the physician is going to break water, that you get a fetal heart rate before he breaks water, after he breaks water, and you document the time that he broke water and what it looked like. So you need a fetal heart rate saying that my baby's heart rate was 135 before he broke my water, or not my personal water, but my patient's water. And then you're going to need a fetal heart rate afterwards to confirm that the baby's still okay. Because what can happen when the water breaks? What can come down first? A cord. And so if that happens, then your fetal heart rate will drop. And a lot of times he'll know if a cord's come down because it's now sitting in his hand because he just broke water. But if you have a change in fetal heart rate and it drops, then you're going to need to evaluate whether or not there's a cord there or not. Okay? You're also going to need to document time that the water breaks. So if we're breaking water, we need to document the time. If they come in rupture, we need to document what time they said their water broke and what it looks like. And the water should be what color? It should be clear, and it may have some like little flecks of white stuff in it, and that's vernix that covers the baby's body. That's fine, but it shouldn't have any green specks or be green. That would be meconium, meaning they've already had a bowel movement. So if they do have meconium, you're going to need to describe it a little bit more specifically. Is it particulate, where there's like particles of stool floating around in there, or is it like thick, like split pea soup thick? Okay? Because one of the things, and we're going to go ahead and talk about this here, just to kind of give you just a limited, you won't have to know a lot about this, but just know that if the meconium is really thick, the physician may make the decision to put in an IUPC and actually do an amnio infusion, which is where they take fluid at room temperature and infuse it into the uterus to replace the meconium fluid that's in there. Okay? But what goes in must come out. Like you should have a relative, it should free flow around in there. It shouldn't all be in there because that's going to overdistend the uterus and keep it from contracting properly. But an amnio infusion, you do have to have an IUPC in place, and we typically only do that when it's thick meconium. But basically what it does is it dilutes the meconium and kind of flushes out some of that thick stuff and replaces it with clean fluid. Okay? So that's an amnio infusion. So if he ruptures her and there's like thick split pea soup looking stuff coming out, he may say, okay, I'm going to put an IUPC in, I'm going to do an amnio infusion, and then you would just watch to make sure that there's fluid coming out, because you don't want the fluid to be retained in the uterus, because then it won't contract properly. Is everybody good with that? Yes, no, maybe so? Okay. Y'all are just like, uh-huh.
After the water break, is it possible for the baby to have a bowel movement?
Mm-hmm.
And how do they know when?
Because it'll turn meconium. It may have been clear when they ruptured, but they could still have a stool, and then you would notice that some of the fluid that comes out would be meconium stained. Or sometimes if it's at the very end when the baby starts to come out and they're delivering, they can have a stool then, because that's a very stressful time for them, because they're being squished and pulled and everything else. So that we call that terminal meconium if it happens right before the baby comes out. Like as we're pulling the baby out, the baby has a stool, then that's terminal meconium. And that usually means the baby's stressed. It's having a hard time. So, but you can have clear fluid that then turns into meconium if they had a bowel movement in that time. Okay. This says nipple stimulation. We don't typically use that because it's very erratic as to what result we get. It can cause hyperstimulation or have little to no effect. Just depends on the patient. But if they're not at the hospital, sex is also something that we tend to tell patients to have to help throw them into labor, because semen has prostaglandins in it that will help ripen the cervix. So if they're wanting to go into labor, sex is not a bad thing. I prefer that you not do it at the hospital, but if they're at home, you could use that. Sometimes when they come in, even if they were not in induction and they want to help speed up their labor, they could start oxytocin at any point while they're there. So you may see them come in because they're in labor, and then we may start some oxytocin or Pitocin to help speed up their labor. Black cohosh is something that you'll see patients sometimes want to use. It has properties that are similar to Pitocin, so if they're using like herbal or home remedy kind of things, that's one that we've heard of that patients will sometimes use. So they don't need to use black cohosh, C-O-H-O-S-H. There's a restaurant in Atlanta that serves some type of eggplant that's supposed to throw you into labor, so we have a lot of women that come in and say, well, I just ate that eggplant. I don't know if it works or not, but they like to use it. Castor oil, remember, is not safe or does not need to be used to induce labor. The nurse's role, we're going to educate the patient. Anytime we do anything, or we're starting them on a different type of medication, or we're going to do a vaginal exam, they need to be educated about what we're doing, because we are definitely all up in their business, and we need to make sure that they understand why we're doing what we're doing. Frequent vital signs checks. Fetal heart rate monitoring, I think we've already discussed with your inductions. Uterine monitoring, when we go in and change the dosage of the Pitocin, or every 15 minutes you're going to evaluate how the baby's doing, how the uterus is doing, how mom's doing, all three things. Cervical dilation and effacement, there's really not any changes. We typically check that no more frequently than every hour, and usually it's less than that, especially if their water has been broken, because we don't want to cause an infection. Fetal station and lie. Station, how far up they are, 0, +1, +2, and that really shouldn't say lie, it should say presentation. I guess lie kind of goes into that, but we want to make sure that the presenting part is a head before we induce them. If we are unsure, then the physician needs to come in and assess them, or they need to have an ultrasound. You definitely don't want to induce somebody that is a breech baby. Has it happened? Has it happened to me? Yes, because the baby was so high we could not determine presenting part, and the physician said go ahead and start the pit, and when the midwife came in to check them and they were 3 centimeters, it was a butt when it finally came down where you could actually feel it. So you need to confirm that it's head down before you start Pitocin. Rate of infusion, typically that's going to be 1 milliunit 1 million a minute, you're going to increase it every 15 minutes. Just know that you're going to increase it to get them in a good contraction pattern as long as the baby's tolerating it. Well, it's usually 1 millunit a minute. That's how it's actually calculated, that we increase it by 1 millunit per minute. We do that every 15 minutes. Let's just say 1 millunit. Mm-hmm. She came in to, it was her patient. And so she came in to assess her that morning, and she's like, "Did you check her?" And I was like, "Yeah, but I couldn't feel a presenting part." And she's like, "Yeah, I'm pretty sure this is not head down." And I said, "Okay." So we got an ultrasound, and it was booby down. We have midwives in the hospital. Because Georgia doesn't allow home births. So if they're having home births, they're not sanctioned. They're not supposed to be. So our midwives do work within the hospital setting. We only have one. We had a couple, but we only have one now. All right, intake and output needs to be monitored. Don't forget about the bladder. A lot of times it's easy to forget the bladder, but make sure that they are emptying their bladder. Either they have a catheter, or we're letting them get up to the bathroom, or they're using the bedpan. And make sure they know that there can be some side effects to the medication, like the swelling or the hyperstimulation. And the reason the hyperstimulation is important is because if they have hyperstimulation, the baby tends to not like that, and the heart rate will drop. So they need to know that if there's a point where they start contracting too much, we may have to adjust the medication to prevent the baby from getting complications from that. So what do you think we do if they start hyperstimming? What do you think our nursing intervention is? What's causing it? So if you've got a baby that's having a massive decel, it may not be a question of turning it down, it may be turn it off. Just depends on the situation. So turn the pit down or off, usually off until we get the baby's heart rate back up. Lateral position, give them some oxygen, potentially give them a fluid bolus to help dilute the Pitocin and also to make sure they're not dehydrated. So those are your interventions if they start to hyperstimulate and the baby's heart rate tends to drop. Okay, let's look at a strip. What is the fetal heart rate? This right here is 120. It's around, it looks like it's about 110 to 120 or 115 to 122, somewhere right there. Depends on which spot of the strip you look at. Like if you look at that one right there, that looks about 110 to 120. Okay. So what's our variability? Which would be? Moderate. Are we having decels? What y'all want to call those decels? What do you think this one is? Early. That one looks early to me. What about this one? Late. That one looks late to me. Probably late. Early. I think this one's early. Usually, if they're having true late decelerations, they're going to be with each contraction. So this would be a hard strip to interpret because typically with late decelerations, we've got to do something about them. But I'm wondering if these are more head compression than placenta, just because you had an early and few lates in the middle. But if I ask you on a test, this is a late deceleration because of where it is. Okay, this would be a late. If I ask you about what would you classify the first decel as, I would think that's early, because if you look at the end, it's back at the baseline. Okay? Alright, so are we worried about this patient? I'm not happy about the strip, but I'm not extremely worried. Why? What are some reassuring things that we do see on the strip? Okay? We had earlies mixed in with our lates. So there was another decel. It wasn't just true lates every contraction. So that makes me feel a little bit better. What about the variability? I'm okay with the variability. It's moderate, which is good. So that makes me... How are we getting that it's moderate? But it's jig-jaggy. So if you saw the pilot... It doesn't have to be... But it is. Because it's going 110 to 120. So that's 10 beats of variability. So it is moderate. It's running a low baseline, so that's something that we may need to look at, because it's running 110 to 120, which is a little bit on the low side of normal, but I'm okay with that. Is the patient contracting? Okay. How often? kind of hard to tell them here. Let's just count the boxes, maybe easier. 10, 20, 30, 40, 50, 60, 70, 80. Almost 2 minutes. So 180, so about every 3 minutes. 180 seconds divided by 60 every 3 minutes. So about every 3 minutes the patient's contracting. So is that okay? And how do we check how often they're contracting? What points do we look at? Beginning of one, the beginning of the next. How do we measure duration? We look at this one. So that would be 10, 20, 30, 40, 50, 60, 70, somewhere between 70 and 80 seconds that contraction lasted. So we're okay with that? Do what? 3 minutes? Each one of these is 10 seconds, so I just counted the boxes and divided by 60 to get my minutes. Because I can't, it's hard to tell on here where your dark lines are.
So from line to line, it's not 1 minute?
Dark line to dark line is, but I can't really see dark lines on here. Yeah. If you've got a real strip, there's dark line to dark line, that's a minute, which means that there's 6 boxes in between there. So I just add the boxes.
And on the top one, when you're getting, when you get the baseline, you say variability. I guess I was doing mine wrong. You don't go by, like on this one where it's coming down or going up. You don't.
That's a good point. You don't count D cells or X cells in your baseline. Okay? That's a good point. You just look at where it is the majority of the time. If it has an acceleration, that's an acceleration. But it's not counted in your baseline. Your baseline is where it is the majority of the time, not a D cell, not an acceleration. So you can't count it here because you can't count that box. This is baseline, and that's baseline.
And where do you get your variability? Through the baseline?
Through the baseline.
How far is the baseline is going?
Right.
Not the detail.
Not the D cells and accelerations. That's a good point. Okay.
Because I was doing them wrong because I had one variability of 55, and I was like, oh Lord.
Yeah. Your baseline does not include accelerations or D cells. It's that period, that point where it is the majority of the time. So you can't use this part right here because it's got a D cell in it. Yeah. Okay. All right. So what is our conclusion on this? What do we want to do for this patient? Is there anything we might want to do for her? Probably turn her. Just see. Maybe that'll help a little bit. It might make you feel better anyway. Okay. Don't know that I would jump to oxygen just yet, but if I saw a couple more of these, they're going to get oxygen.
When you're counting out the frequency and the duration of the contraction, each line is 1 minute, but when you're counting the box is seconds.
Yes. It's kind of hard to tell on here, but this is a minute, I think, right here, because this is actually 10 seconds here. Each little box is 10 seconds. If you've got a really good defined strip, and let's see if y'all do on yours. Y'all have your packets. Yeah, like that first one. You see those darker lines? From darker line to darker line is a minute. But if you look at the boxes in between, there's 6 boxes. So 60 seconds equals a minute. So however you need to do it. Some of the strips just don't show it. So each one of these is 10 seconds.
When you start to count, like where do you start at the beginning?
From where it leaves, so 10, 20, 30, 40, 50, 60, 70, somewhere between 70 to 80, because it kind of cuts off in the middle of that. So start where it leaves the baseline and where it comes back to the baseline.
Okay. And that's duration?
Yes, that'll be duration. And then frequency, you just count from here to here. Okay? Alright, I do want to, if you ever hear the term nadir, N-A-D-I-R, nadir or nadir, that's the lowest point that a D cell reaches. So if you ever had a question that said, you have a deceleration where the nadir is located after the peak of the contraction and returns to the baseline 10 seconds after the contraction's over. Nadir just means the lowest point that the fetal heart rate got to. Like on this, that is the nadir. That's the lowest point that the heart rate drops. It's just a different terminology. On that one, yeah. And like on that one, it's probably 100. And we use that sometimes when we're classifying or when we don't know how to classify a D cell and we're documenting on it. We'll put with a nadir of 90 lasting so many seconds. But nadir just means the lowest point of that D cell. Okay. What about this one? What is your heart rate? Probably average out to be 150. Is it moderate variability? Yeah, that looks pretty good. Because you're actually running about 140 up to about 160 almost. So, look, this is 150. This is 140. So if you're looking at, it's going to average to be 150. That's where it is the majority of the time. But you do have some that are above that. Does everybody see that? Yeah. But it's going to average to be about 150.
And that's variability.
Mm-hmm.
Okay.
How much of this you see is your variability. Okay?
So are these answers like black and white, like there's a definite?
I will give you a little leeway on them because I would call this based on, look it up here right now. Just
That's why I don't get how we can do two numbers.
because you're looking at two different things. You're looking at the lowest that the baseline gets and the highest. So if you look here, that's on what? 140 it looks like.
140.
Right? And then what's this number on? 155 or 160? So if you look at 140 to 160, that's 20 beats of variability. You with me? Tiffany?
So a D-cell, it has to go all the way down.
It has to be below that baseline. So if you're saying the bottom number on that baseline is 140, it has to drop below 140. Okay? Right. That's why you find your baseline first, because you got to know what your baseline is to bank everything else on.
So you can have them coming down looking like D-cells, but they could not be D-cells if they're not below the
Right. Like if you look at this, some of y'all might have thought that was a D cell. But that's not a D cell. It's just baseline. Because if you look at it, it's not like it drops and then comes back up. This is just the normal heart rate variance on there. Now if it dropped below here, then that would be a D cell.
So the very last one, is that a D-cell?
This is a D cell. That is a D cell. That is a D cell.
So it has to be,
It doesn't have to be a big change.
It has to go below.
But it has to go below your established baseline. Now, with your variables, it's very obvious that it's a variable. Your earlies and lates may be very subtle. If your baseline is 120 to 130, a late could actually be a drop to 115, which is only 5 beats below your baseline. So your lates can be pretty subtle. Your variables tend to be very abrupt, and you can usually see them. But a D cell is classified as a decrease below the baseline, the established baseline for that patient. Yes? So if your baseline is 120 to 130, and you had a dip that goes down to 110, that's a D cell. Okay?
On the HASI, are we going to have, like, we can have to fill in the blanks for numbers and then.
Oh, like for heart rates and stuff? I'm trying to think what we did last time. I don't remember there being a ton of strips on there because that's kind of, you won't be interpreting those the majority of the time. If you work on the floor, you might be. Not without special training. So I think those are going to be more generic questions about identify if this is a variable D cell or early D cell or late D cell, more than, fill out all this information on the fetal heart rate. Okay? Alright, so looking at we said our baseline was what? 145 to 160, somewhere around in there. So what is our variability? At least 10 to 15, which qualifies it as moderate. So if I ask you what's the variability, I don't want you to put 10, I want you to put moderate. You're just using those numbers to determine which one it falls into, okay? So we're going to say our baseline is 145, or let's just say it's 150. We'll use a one number. Baseline is 150 with moderate variability. Is everybody good with that? All right, do we have any accelerations? I don't really see any. Do we have any decelerations? Yes. And what would we classify these as? Variable D cells. Because, yeah, because you can't say this one's early because there's no contraction associated with it, right? This one does appear to be in some condition with a contraction, but it's actually before it ever peaks. And this one's just stuck out in la la land too. So your variables don't have to occur at any certain time. The reason you're going to classify it as a variable is because it drops really quickly and it goes back up really quickly, which gives it a weird appearance. It looks like a U or a W or a V. And all of these have a really abrupt appearance, don't they? Okay? Yes? So those are variables. What does that indicate? Cord compression. So what are we going to do about it? Turn our patient. Are they contracting? How often? Just look at these two. About every 2 minutes. How long are they lasting? 60 to 70 seconds on that one. About 100 seconds on that one. 90 to 100. Okay?
I have a question on that bottom one.
Okay.
When it's not down like what do we call it, the zigzag, like that was kind of like a straight. No, that still is contract.
Mm-hmm.
Because that threw me off on these ones. They're both, no zigzag.
We'll talk about that.
Okay.
If you have one that looks like that, they're probably throwing up or pushing.
Okay.
If you see it kind of boxy looking. There's one in there that the patient's doing one of the two. Okay. All right. We talked about McRoberts positioning. Why do we put patients in McRoberts positioning? Shoulder dystocia. Do they have to be diabetic to have a shoulder dystocia? No. They do not have to be diabetic to have a shoulder dystocia. So if you ever have a patient and the physician says, I think we got a big baby and we might have a shoulder, put them in McRoberts. Remember, that's going to be, legs need to be spread out as much as possible and they need to be pulled back up. And you can see how she's kind of curling around that baby and opening up the pelvis. All right, there's another strip. I don't know really why I put them so randomly through here. I guess to give y'all a break. What would y'all call the fetal heart rate, assuming that this is 120? 130. I would go with 130 to 140. That's got to be something else. Now let me count them because this one's a little bit different. This one's measured a little bit different. So you're right, it's right at 130. These boxes are a little bit different. All right, so 130, what would we call our variability? I think it's moderate. It's close to moderate. All right, do we have any accelerations?
No.
Do we have any decelerations? Okay. What do you want to classify them as? You do have contractions. Y'all see the contractions? They're just really subtle. So there's a contraction. Let's see, it ends there. Okay, what about this one? Probably early. They look to be early. The contractions are just not picking up very well. Okay, so are we concerned? Our heart rate's within our normal range. We've got moderate variability. We're thinking these are early decels, so I don't see anything on there that's concerning to me at this point. Okay?
So does early mean zero?
Mm-hmm.
Okay.
So, to notice a contraction, if it goes anywhere above the baseline, it's a contraction.
Yes. We're going to go with yes.
What's in here is a contraction.
That looks like irritability to me. That's why I said yeah. I can't really determine where that contraction is. It just looks like this to me. So that would call that irritability because I can't tell you where the contraction is. On this one, you can obviously tell that there is a contraction there. It's just not picking up very well. So you look at your front sheet of your strips versus this one. Does it look different to you? Okay. I won't give y'all something on test that's questionable, like what the heck is this? Yes. But I will tell you that sometimes you will see a pattern like this if they're dehydrated or if they are having an abruption. This patient is not having an abruption by any stretch, but they will have that weird, it just looks like kind of wavy on the bottom. But I won't give you anything like that. It's a question on the test. I just want you to know the textbook for the test.
So contraction on the bottom strip, anything that comes above is a contraction.
Right.
Whether it's zigzag or
Right.
straight, like a mountain.
There's never an absolute nursing.
There it is right here.
No, I mean, there's not. No, that patient is obviously contracting. That's not what I'm saying. I'm saying that with a patient, you could have a patient mashing on a toco and making it look like a contraction that would give it that boxy appearance. But assuming that this is your patient who is not in there doing anything inappropriate, this patient is having contractions. Okay? There's always an exception to the rule. Alright, prolapsed cord, we talked about that. What are your nursing priorities if you are the one that does a vaginal exam, which you won't be as a student because you can't do vaginal exams. But if the nurse finds a prolapsed cord, does a vaginal exam, and there's a cord, what does she do? Don't let go. Apply pressure. Put them in Trendelenburg position. Call the physician because they're going to have a C-section. Okay. Why would you put them in Trendelenburg? Because it's taking the pressure off the baby. It's pushing the baby back up, so hopefully it'll get off that cord. Alright, abnormal presentations. I think we've talked about those pretty much as we can. If they're in an abnormal presentation, such as breech or frank breech, footling breech, or transverse, what is the delivery method? C-section. Alright, so let's talk about C-sections. Which patients could potentially have a VBAC, or a vaginal birth after cesarean? Low transverse, if they've had one C-section. Okay? So if they've had one previous C-section that was a low transverse incision, then they could potentially be a candidate for a VBAC, which means vaginal birth after cesarean. Okay? But you also have to look at the reason they had the C-section in the first place. If they had a C-section because the baby was too big and this baby's just as big, what's the likelihood they're going to deliver vaginally this time? Slim to none. But if they had a C-section last time because the baby got into stress and had a massive decel, then those could potentially deliver vaginally. So look at the whole picture. Okay? Let me see what time it is. Alright, what if I give y'all a 15-minute break? Be back in here at 12? Sorry, I gotta go to the bathroom and we gotta finish this lecture. I've rubbed myself off.
Okay. Really?
I hope she doesn't get us a podcast. I don't think so. I don't see nothing up here.
Okay, talk to me.
I love to do that too, but I think when I do the tattoo, actually, I always say that. That's what you want to do. I mean, I don't care, but
Hey, do you want to come back then?
I'm like, everybody calls me on top of that. And then you have it together. I always call somebody. I'm like, that's all I need. 5:45 to do it. Now, tomorrow we got to do it at 6. Oh, I ain't got no more money. Oh, I know it. Jesus. But then, I have one clinical a week until mid-October.
You can take mine, because I got like 3.
I had 3. But then like the second or third week in October, I have 3 that were horrible. I'll be like,
We go to Lanier tomorrow, Saturday we come here, Monday we go to
I get 3 days.
East Alabama, and then that Friday I go to the school nurse, and then back to East Alabama. Yeah, I don't do it great. Oh, my whatsoever surgery's on Wednesday.
I had the best time there at surgery.
Did you?
It was fun. I got to see a lot.
I went in with Dr. Ducat, but he was nice at first, and then I didn't understand what he was talking, and then he got rude, and then he was asking me all kind of questions about his nurse. He was just getting a little personal for me, but I had no idea now. It's not too personal.
I have a different You have, what's your name? I have this Alabama.
I'll show you the name.
The physician, he's packing up, he's there in a lap coat, and he's like, yeah, I think this is the artery that I'm stapling right now. I'm not really sure. And I think this is what I'm supposed to be removing. And one of his nurses, she was like, you got them scaring her. She hasn't said a word. She's just like, I know. I was like, no, I'm just going to right now. That's what we're talking about.
Me? I'm sorry. Who knew there was so much involved in having a baby?
I've had a C-section and a real birth.
That means we're doing our job, make it look easy.
Yeah.
All right. So we were talking about VBAC before I had to take my little bathroom run. So VBAC. What incision of the uterus could potentially have a VBAC? Which one do we say? Low transverse. So if they have a classical incision to the uterus, they cannot. Why are we so leery of letting somebody that's had a C-section have a vaginal birth? Because the uterus has a scar on it, and that scar can actually rip open and cause a uterine rupture, which can be detrimental for babies. So uterine rupture is the reason that we are leery of VBACs. And although it doesn't happen all that often, it can happen in up to 3% of the people with VBAC, it's still a potential risk. Okay? We actually have had a uterine rupture very recently at West Georgia. So everybody's kind of leery right now. But all right. If they're having a C-section, what are some things that might be a little bit different if they're having a C-section versus coming in for labor? Think about just general surgery stuff. Can they have anything to eat? So they are MPO after midnight the previous night. What else?
They will have a catheter.
They will have a catheter. We'll put a catheter in once they're numb. They do, and I'm sure this is probably going to be across the board. We just haven't seen it in all the hospitals yet. They're doing a new prep where the patient actually has to shower the night before and the morning of surgery, wash them with a special wash, and they give them specific instructions on how to do that. When they come into us, we have to make sure that prep is done, but as far as our prep is concerned, they also have to be shaved or clipped because we want the incision to be free of hair. We also prep their abdomen when they're in the OR with a special cleaner. We use ChloraPrep. You could see Betadine or something else used at different hospitals. But we use ChloraPrep, so the incision site itself has to be sanitized. Okay. When they come into labor and delivery, we do put them on the monitor. We do an NST on those patients to make sure that the baby looks okay, just to see if everything's looking fine. We still do our admission assessment just like we would do if they were coming in for labor, so all those questions, the lab work, all that stuff still applies. We ask them if they've been MPO. We would get consent forms signed, so if they're having a C-section, we need a C-section consent. We may need a blood consent. If they're having a tubal ligation, they need a consent for that. They need an anesthesia consent. So there's usually at least 3, if not 4 or 5, consent forms that we have to make sure that are on the chart and signed. When the patient goes back to the operating room, we typically put the spinal in the operating room. So we have to assist with that. And we already talked about how they do that. Dangle position. They get a fluid bolus before they go back. And they do get numb really quick, so we try to lay them down. Once we lay them down, we would do the Foley catheter, because then they're numb, they don't feel it anyway. There's no sense in them having to go through filling a catheter if we're going to numb them up. So they would put a Foley in. In the OR, what should you not touch? Anything blue. Anything blue. Because all of your sterile stuff is going to be blue. So there's drapes and there's stuff on the where they put the instruments, so all that stuff is sterile. Let's see what else I can tell you about incisions. Who's responsible for managing that patient, like physically managing that patient's airway and stuff when they're in surgery? Anesthesia. So anesthesia kind of runs the ballgame as far as meds and that type thing in the OR. They're the ones that controls the meds. They do the vital signs on the patient, so that does kind of take that out of your hands, although you have to be sensitive to what's going on in the room, so if you need to get something or assist, that you can. Okay? How do they check to make sure that the patient is numb enough to have surgery? They pinch them with little Alice, we call them Alice clamps. And so what do they say? Do they tell the patient, although I did have one other day that told the patient, I thought it was crazy, but they usually say, testing Alice. Or anesthesia, you'll hear them say, how's Alice doing? Alice is good, because they'll pinch them really hard to make sure the patient doesn't feel it. Usually it's superficial, so probably not, but I guess if they pinch deep enough, it could be a little bit of a breeze. So once they've tested to make sure that, Alice is fine and that they can't feel anything, then they would make the incision. Does the spinal take away the pain? Does it take away the pressure? It doesn't take away the pressure that they're going to feel when they actually get the baby out. Now, they shouldn't feel anything in our legs. I mean, you could sit there and pinch them in the leg and they wouldn't feel anything. But if you are pressing up here, remember we talked about that the spinal doesn't go all the way up to here, otherwise you couldn't breathe. So they will feel the pressure of them pushing on their abdomen to get the baby out. But they shouldn't feel pain associated with that. Okay?
Is there a possibility that you couldn't feel anything?
They usually always feel. You ever seen a C-section?
Yeah, I had one. I felt nothing.
That's great, because most of the time, if they have to press pretty hard, and normally they do have to press pretty hard to get the baby out, the more they have to press, the more pressure you're going to feel. So maybe they just didn't have to press very hard to get the baby out.
Might have been the anesthesia got kind of like to talk because I wasn't breathing.
Yeah, good man. Distraction. Immediately after the baby. They actually just go in there and they manually extract the placenta. Alright, same times are important as they were if they were laboring, except for you add a couple. You got to know what time they go into the OR, what time they start the procedure, what time they make an incision. They call it incision time. They will do something called a time out. which basically means that they say, this is Miss Jones, she's here for a repeat C-section and a tubal ligation. And the physician says, I agree, anesthesia says, I agree, the nurse says, I agree, everybody agrees that this patient is here for this particular procedure. It's known as a timeout. It should be done before the incision is made. Okay? So timeout. Yep. And they don't make a big deal out of it. It's just something that's part of the routine. But they all stop and they'll say, okay, it's time for a timeout, and everybody just goes, this is Miss Jones. She's here for a C-section, for failure to progress. Everybody agree? We agree. Everybody gets back to business. Okay? So timeout. Incision time, you need to know what time they rupture the patient. So if the water is not already broke, they'll break the water when they go into the uterus. So you need to note that. And delivery time of the baby. And typically the placenta, as soon as the baby is handed off to nursery, they will remove the placenta. So typically you need to be alert to that as well. But it's usually about a minute after the baby's born. All of it. Note what time the baby's born, and usually the placenta will deliver, once they hand the baby off to nursery, they will go and actually manually extract the placenta. So it's usually about a minute after the baby's born, but just be aware of what time the placenta is taken out of the body. You will also document the time that they're actually closing the patient, and the time you leave the OR, and the time you get into recovery. So it's kind of increments that. So in the room, incision time, rupture time, baby time, placenta time, closing time, and what time you got in the PACU or recovery room. So you got to know all those times, okay? And closing, yes. Yes, I'll talk about that. Counts, because you're in the OR and because there's being things put into the patient, before you start the case, they will do something that they will do a count. So basically the scrub tech will count all of her instruments, and they will say, I've got, my instruments are correct, and if they have passed anything off to you, because sometimes they'll give us a ring forceps so we can pick up the bloody laps and count them. So they'll say, my count is correct with you having a ring forceps. And then you'll count your needles, and you'll count your blades, and you'll count your Ratex and your sponges. So you'll count everything, and that'll be written on a board before you start the case. Then before they start closing the patient, we usually do at least 2 counts during surgery. So once the baby's out, we know the baby's fine, they'll do a count. So you'll go back through the whole thing. Anything that they've passed off the table or any laps that are bloody that's been passed off to you. So let's say you started with 20 laps and you got 4 and you don't know where 1 is, you got a problem. Okay? So your count has to be correct before you can move forward in the surgery. So if you've lost a lap somewhere, until we find it, everybody looks for it.
Is that to prevent, I know, somebody had left something in somebody, is that to prevent that?
Right. And once you've confirmed that your count is correct, once you've counted with the scrub tech and everything's fine, then you look to the primary physician and you say, Dr. Jones, your count's correct. And he'll say thank you and he'll keep going. Okay, but if anything's missing, we got to find it. Needles, instruments, sponges, whatever. Got to find it. No, we usually do it after the placenta's out. Usually before they put the uterus back in, like maybe while they're stitching up the uterus. And they can be working while you're doing it, but if there's something wrong, then we got to stop and find it. But he may be stitching the uterus while you're counting, and she'll say, he's got 1 needle, and here's 2, 3, 4, and 5. So he can be using the instruments, but she has to point out where they are so that you physically see them and they're being used. Yeah, got to do counts. Okay, once they've finished the procedure, they will put a dressing over the incision, just like they would with any surgery, and now they become a postpartum / surgery patient. Once they're in the recovery room, anything that you would have done for that postpartum patient, you're also going to do for the C-section. You're just adding that they've had an incision. So along with the fundus and the bleeding and all that stuff, you're going to add checking the incision or the dressing to make sure it's clean, dry, and intact. Okay? Questions about that? Make sure that when you're doing a fundal check, because I don't think I mentioned this earlier, but it's especially important with your C-section patients, you want to make sure that you put your hand over that incision and provide some support to that lower uterine segment. Because if you're going to get in there and rub that fundus, you definitely don't want to be disturbing or busting open an incision, an internal incision, okay? So make sure you support the lower uterine segment to do your fundal rub. It's a good habit to get into even if you're doing a vaginal delivery. Just support that lower uterine segment before you do your fundal rub, okay? Questions about that? Okay. There is your C-section. It kind of shows your different incisions. We usually see either the low transverse or the classical. This is like a low classical incision, but these are the two that we typically use, transverse or vertical. Okay. All right, here's another strip. What is your fetal heart rate baseline on this one?
130.
It's going to average out to be 130, but if you're looking at top and bottom numbers, you're probably looking at 125 to 132 or 33, somewhere in there. So is that going to classify as moderate? Yes, because if you're looking at 125 to 132, that's what, 7 beats of variability? So that would be moderate. Do you have any D cells? Do you have any accelerations? Yes. So if we're looking at this as an NST, and we're looking to see if it's reactive, is this patient strip reactive? How do you know? Because if you're looking at it, and we said the baseline, let's just average it and say the baseline was 130. Okay? So 15 beats above 130 would be 145, right? 130 plus 10 would be 140 plus 5 is 145. So you have to have accelerations that go up to at least 145 beats and last for 15 seconds, with each one of these boxes being 10. So it needs to last a box and a half, right? So this one looks like this one definitely, it goes up to 160, and it lasts for about 3 boxes. That one's going to qualify, that one's going to qualify, and that one's going to qualify. How many do you need to be reactive? 2 in about 15 minutes, right? So you're good. It's a nice reactive strip. Do you see any contractions?
Not really.
I don't really see any contractions. These little things that you're seeing are not contractions. Those are fetal movement. Okay? What if this was your strip but the patient says they feel contractions? Check the monitor, check the placement of the monitor, because where should the toco be placed? On the fundus. So let's say that this patient is 36 weeks. Where should the toco be? Should be above the belly button. So if your toco is below the belly button, that could very well be why you're not picking up contractions. What if you move the toco and she still says she's feeling contractions? Well, if she's early, you're not going to want to put a monitor in because then you're going to commit her to having to be labored. I would probably feel her belly. Tell her to call you in there every time she feels that pain and feel her belly and see if you feel anything. Because it could be intestinal cramping that she's feeling. Or just a virus. Okay. Okay. What about your baseline on this one? 130 is going to be the average. If you could see it a little bit better, which you can't because it's so blurry, I would say that the baseline's probably 128 to 131. So how many beats of variability is that? 3. So that would qualify as minimal. Because there's some jig-jaggedy to it, but there's not much. So it is minimal. Do you see any accelerations? Do you see any D cells? No, I don't really see any D cells. Do you see any contractions? Okay. So are we happy with that? Not particularly, but it does look like here at the very end that we may be starting to have an acceleration, hopefully. So maybe we're getting there. So what would your interventions be? Just watch it. Just watch it. Because this doesn't alarm me if it gets better or it has been better. It does alarm me if it stays like this forever. So just watch it and see what happens. Assuming that this is a contraction stress test, would she be positive or negative?
Positive.
Positive. Do we want a patient to be positive? No. We've already evaluated the strip earlier and decided that the first and last were early, but the 2 middle ones were late. So if you were doing this as a contraction stress test, this would be a positive contraction stress test. Do you think the physician's going to let her labor?
No.
Probably not, because she had some weight decelerations. Okay? So you want a strep, if you're doing an NST, you want it to be reactive. If you're doing a contraction stress test, you want it to be negative.
You said that people that went in labor don't know how to.
Probably. We don't do a lot of contraction stress tests because it's kind of, if we're going to do a contraction stress test, what we normally do is bring them in, induce them into labor, or let them labor, and however they tolerate labor is your contraction stress test. If they don't tolerate labor, then they get a section. We don't typically bring patients in just to do a contraction stress test. But okay, let's talk about the newborn. I know that newborn is later, but this is going to be that immediate care of the newborn because that kind of falls into intrapartum because that's when we do it, okay? So this will be on your test, this couple slides here. Your infant care is going to be divided into 3 different phases. We're only going to discuss phase 1 care. We will cover phase 2 and 3 when we cover newborn. We're just going to cover phase 1 care here. So phase 1 care, this is going to be right after the baby's born. What do we do for them before they leave that delivery room? Okay. Thermoregulation, what does that mean? Keep them warm because they don't have the ability to keep themselves warm. It stresses them out. And the worst thing that we can do for a baby is to not keep them warm and put them into cold stress, and then they can develop respiratory distress and cause a lot of problems. So keeping them warm is a big deal. So what do we do to keep them warm? We have the warm, whatever that thing's called, that just escaped me. The warmer, the infant warmer. We turn the lights on, so that's part of what nursery does when they come over to get ready for the delivery, is they reach up and turn the light on so that the bed is nice and warm. Okay? What else do we do? We swaddle them, but we don't usually swaddle them right after they're born because we're looking at them and assessing them. You wipe them off. Because how does your body lose heat? Why do you sweat? You sweat because when you've got all that wet on you, that tends to lower your body temperature. That's why we sweat. A baby comes out wet. So if you don't dry that baby off, it can drop their body temperature pretty quickly. So we dry them off. And the first thing you see the nurse do is dry that baby off. They set them in that warmer. They pick the baby up and jerk those wet blankets out from under and put them on dry blankets because you don't want the baby to stay wet. So get them out of the wet. Dry them off. Get the wet blankets off of them. All right. What are we going to do for cardiorespiratory function? Suction them. So what are the ways that we suction a baby? What are the 2 ways? The bulb. The little green thing, usually green. I guess they could be different colors at different hospitals, but ours are green. You're going to hold it away from the baby and squeeze it in, put it in the baby's nose and suck out, and it gets all that snot and mucus and stuff out. So they can bulb suction them. How else can they suction them? Just like you would do with an adult. It's just a much smaller tube, so they can do some deeper suctioning if they need to. Okay. What else are they going to look at? How are they going to know that cardiovascular-wise if they're doing what they're supposed to? They're going to check it. Their pulse should be 110 to 160, at least greater than 100. If it's less than 100, we have a problem. Okay? So the heart rate should be 110 to 160, but needs to be at least greater than 100. How are we going to know if that baby's getting into some respiratory distress? Retractions. What else? Grunting. They grunt. That may be what you're thinking of. Their heart rate's going to elevate. Their breathing rate's going to elevate. Usually if it's greater than 60, we are worried. Because remember, your respiratory rate in your babies is higher anyway. But greater than 60 would be tachypneic on a baby. Okay. So respiratory rate greater than 60. Retractions, grunting, nothing, anything else? Color would be, what would be bad? Blue or dusky. We talked about expiratory grunting. And they can also have nasal flaring. Now, babies do grunt occasionally when they cry. That's not abnormal. This is a grunt that usually happens with every cry. And you'll see some of the other symptoms, the nasal flaring, the retractions. They'll get kind of dusky in color. Okay. Why do you think I put GIGU on there? Because you need to know when they pee or poop. So if that happens within that initial period of time, if they come out and they were pooping as they came out, which is called terminal meconium, that is counted as their first bowel movement. Why do we need to see if they can have a bowel movement? Because we need to know if their GI tract is functioning. If they're pooping, then everything's okay. You do have babies that are born without a anal opening, so we need to make sure they're pooping. Which is also the reason a lot of times that they will do a rectal temp on a baby, so that they get a good core temperature on the baby, but it also checks to see if the anus is open. Okay. What about peeing? TTing. Same thing. We need to make sure it's functioning, so that's recorded. And a lot of times they will tend to urinate when they first come out, so that would be recorded as well. Okay. All right, APGAR scoring. We're going to talk about that one on the next slide, so just hang on to that one. Security. What do we do for security on that baby? Okay, we band them, so they're identified with that mom. So mom gets a bracelet, baby gets a bracelet, and then significant other or whoever's going to be her support person gets a bracelet. All of those numbers match, and that's how we identify that baby goes with that mom, and it's done before they leave the room. So nobody leaves the room until that's done. We also do something called a little baby low jack, but it's our security system. It goes on the baby's ankle, and it's a little device that will alarm if it's cut off, like if somebody's trying to steal the baby and they cut the band off, it would alarm. Or if they get close to an exit door, it's going to alarm. So it's another safety feature so that we know, and that particular box is to that baby. So it'll show that baby Jones is the one that's alerting, so they know where to go. Try to find it. Yes. Anybody that doesn't have, and it's different per hospital, but ours have the pink swipes on it. If they don't have pink on their arms, their name badge, they don't get a baby.
What was the name of that?
We call it baby low jack, but it's just a security box that goes on the baby. I don't know the official name. All right, bonding and breastfeeding. Remember we talked about that immediate postpartum period is the best time to get them to breastfeed. So if they're going to breastfeed, we want to make sure we get baby back to mom, if at all possible, and do her breastfeeding. Medication administration. What medication do we give? Vitamin K goes in the acid lateralis. What else do we give? The eye ointment goes in the goes over the eye. It's an ointment, so along the lower conjunctival sac or the lower canthus. We also give them hepatitis B, the vaccine, if they want that, if the parents are okay with us giving that. But the two biggies are going to be your vitamin K and your eye ointment, whether it be erythromycin. That's what we use at our hospital. Okay. Why do we give them the vitamin K? Because their gut is sterile, and the gut is what produces that. They don't have the ability to produce that when they're born because their gut's sterile. So vitamin K helps them to clot. Okay. Why do we give the ointment to the eyes? To prevent an infection that they could have potentially gotten from coming down from the birth canal. The overall appearance. What do we look at for the baby? Why does it just say overall appearance? 10 toes, 10 fingers. The eyes look fine. They look set in the head correctly. They're not low set. There's nothing that looks abnormal, nothing that's worrisome, because that would indicate that we need to do some further testing immediately. So overall appearance is going to be looking at it to make sure that it looks appropriate, if there's not anything that's alarming or that needs further assessment. All right, gestational age assessment's not on here, but they do want to make sure that they are of the gestational age or appear to be of the gestational age that we thought they were. If we thought we had a 40-weeker and really we had a 32-weeker, then that baby's going to need more care. But that's usually pretty evident because they can look at the baby and look at those distinctive features to see what's going on there. Okay. We also need to look at the cord to make sure that it is a 3-vessel cord, because that is something that we have to document. And you should have 2 arteries and 1 vein, but you must have at least 1 artery and 1 vein. Otherwise, that baby would not be there. Okay. Here's your APGAR scoring. You are given a 0 to 2 scale for each one of these. APGAR stands for activity, pulse, grimace, appearance, which is your color, and respirations. So let's look at that. Activity. If there is no activity, then that is absent. If their arms and legs are flexed, that is 1. If they are actively moving, that is 2. Okay? Pulse. If it is absent, they get 0 points. If it's less than 100, they get 1. If it's greater than 100, they get 2 points. Grimace. If they are flaccid, that's a 0. If some flexion of extremities, then that's given a 1. And then if they're actively moving or sneezing or coughing or any of that, when they sneeze, they'll kind of jerk. That will be given a 2. Appearance is your color. If they are blue all over, they get a 0. If their body is pink but their extremities are blue, they're given 1. And if they're completely pink, they're given 2. This is usually the one that the babies get counted off for because it takes a while for their body to perfuse their little hands and feet. So a lot of times they do get dinged on color. But that's okay as long as everything else is fine. Respirations absent is 0. Slow or irregular is 1. If they are crying vigorously, that would be a 2. So what is the best score that you could get? 2, 4, 6, 8, 10. So a 10 would be a perfect APGAR score. And those are typically done at 1 minute after delivery and 5 minutes after delivery. So when nursery says, what's the delivery time, and you say 13:03, at 13:04 they're going to do an APGAR, and then 5 minutes later they will do another APGAR. Okay? Most of your babies will be somewhere between 8 and 10, and usually it's counted off for color. But if they are less than that, if they are, let's say, less than 7, then some resuscitation is probably going to be needed.
That one that we did, she did a 7 or 8 for the color for that time. They had off 2 colors.
Yeah, she got a 7. It had to count it off for something else too.
I thought she said color for both times.
Because that would have been, she must have counted off 1 point for something else.
Oh, okay.
But she could have counted off color both times. Yeah. At least for that first time. Okay? Alright, yes. I know. Sure. Pulse is absent is 0, below 100 is 1, greater than 100 is 2. Okay? Alright, so let's do one of these and see if you can classify it. Baby has a heart rate of 110. Do y'all want to count it as we go, or y'all want to do it and just count at the end? Okay. Baby has a heart rate of 110. 2 because it's greater than 100. Has a weak cry. 1. Flex. It'll flex its arms when prompted. 1. Grimace when you tap the foot. 1. And it has acrocyanosis. 1. Acrocyanosis means the trunk is peaked but the extremities are blue. So acrocyanosis, meaning that the extremities are blue. That would be a 1. Acrocyanosis would be 1. Okay? Grimace when they tap the foot.
Where's that on?
If you look under grimace, it's going to be a 1 because you're having to elicit it.
I don't have a grimace. I have a heart rate, a respiratory, a muscle tone.
Reflex.
A reflex.
Reflex is grimace. Okay? So we gave a 2 for heart rate, 1 for cry, 1 for flexing, 1 for grimace, and 1 for acrocyanosis. What is your APGAR?
6.
Are we concerned if it's 6? you're going to have to do something. That baby needs to be a little bit more alert than that. So maybe it just needs to be dried off and stimulated a little bit more to get everything rolling. Okay? Below 7 is probably going to require some type of resuscitation. Now, of course, if you've got a 3 Apgar, that's going to be a lot more resuscitative efforts than if you've got a 6 or 7. But there's probably going to be some intervention that may be needed to get that baby motivated.
So if it's a 7, we don't need anything.
Depends on what you're counting off for. I mean, if they got a 0 for pulse, we got a problem. Right?
We can do appearances what you do. We only got 5 things we chose from. We didn't score them on them.
No, we did.
I did.
We had 5 areas.
What did we do on the appearance?
Appearance, we said acrocyanosis, so it was 1.
Oh, I thought that was the breathing.
Mm-mm. No, the cry was breathing. Let me go back through them. Heart rate of 110, a weak cry, flex when prompted, a grimace when you tap the foot, and acrocyanosis. That should be 5 different things.
I'm looking at when I went down the line post-delivery again with my acronym and what that means.
Okay.
Okay.
All right. Let me ask you a question. If we had a 0 on pulse, what would be your nursing intervention? CPR. If they don't have pulse, you gotta do it for them. So, if you had a 0 for pulse, then there is going to be an active resuscitation. So a lot of it's going to be what you're counting off for. And where is your placement for CPR on an infant? Nipple line. In the middle, but at the nipple line. And how are you going to do that? Are you going to do it with a hand? No. 2 fingers? But the easiest way in the hospital is to wrap your hands around the back of the baby and use your thumbs. Okay? Alright, I did just put some pictures of just babies up here because I want y'all to realize if you haven't been to labor and delivery, but they don't come out like they do on television where they're nice and clean and not slicky and nasty looking. They do have vernix, and that's what this is. It's just that white stuff that helps protect the baby's skin, and that's normal. The earlier they are, usually the more that they have. So if they're really early, they may be covered in that. If they're early, they may have that fine hair, that lanugo hair on them. But I wanted y'all to see what it really looks like when a baby comes out, because they're not usually nice and clean. They're kind of slippery. Okay, let's look at some Pitocin math.
When you put an eye drop in the baby's eye, you open it?
You gotta. You're not using drops. You're using the ointment. But you just don't want to touch the the bottle, whatever you want to call it, to the eye. You're gonna start the ribbon and then put it along there, and then they can close their eye to distribute it. Okay, are y'all ready?
Yeah. We need to get our calculators in.
Yes. These are some of the problems off of that Pitocin math sheet that you have. I didn't put all of them on here. I just put some of them so you do have the answers to these. We are going to work a few. All right, the physician has ordered Pitocin to infuse at 15 milliunits per minute. The label reads 20 units of Pitocin in 1,000 milliliters of RL, which is usually what we use in labor and delivery, which stands for Ringer's lactate, or you could see LR, which is lactated Ringer's. How many milliliters per hour should you set the pump to infuse? Because if you're infusing Pitocin, it should be on a pump, correct? Okay. Okay. All right. So let's start with what we know we have. We know that we have 20 units, and by the way, U is not an approved abbreviation. You do have to write it out, but for time reasons, I'm just going to put U. You have 20 units mixed in 1,000 milliliters. Everybody go with that? We need to find out how many milliliters per hour. So is there anything that we need to do to milliunits per minute to get it to units per hour that would help us out here? Okay, so we've got 15 milliunits per minute. How many milliunits per hour do we have? How many milliunits per hour are we given? Because you would take 15 and multiply it times what? 60 to get how many milliunits per hour, right? What is it? I don't know. 900? So now I know that I've got 900 milliunits per hour. Right? But can I put that in here? This is in milliunits and this is in units. Okay, so I've got to change milliunits to units. How do I do that? Okay, which way? Everybody agree with that? So all I did was I took what they gave me and I switched it around into what form I needed in. So 15 milliunits per minute is the same thing as 0.9 units per hour, correct? Can I plug that in down here? So I can put 0.9 units. I'm just going to put per hour in parentheses. And this will cancel out, which leaves milliliters per hour. Is that what it's asking me for? Okay. So 20 times x is 20x. 0.9 times 1,000 is 900. So how many milliunits or how many milliliters per hour should I set my pump? Okay. Just a different head. Everybody okay with that? Let's work another one. Alright, the physician orders 24 milliunits per minute of a medication. The bag reads 20 units of medication diluted in 1,000 milliliters of IV solution. How many milliliters per hour should you administer? So y'all tell me how to do this one.
20 over 1,000 milliliters.
Okay.
Take the 24 milliunits and multiply it by 60.
Gives you 1440. What's my label for that?
An hour.
Milliunits per hour. Okay. Now what? Change milliunits to units. So 1, 2, 3. So I'm actually given 1.44 units per hour. And that goes over x. 20 times x is 20x. X equals?
Is that 1 for
Here?
no, I mean
1440.
144.
1,440, yeah. Depends on how many units of Pitocin you have in that 1,000 milliliters. I know it's working out where it looks like you're ending up with the same number, but if there was 30 units of Pitocin mixed in 1,000 or 20 units mixed in 500, it would completely change that. Yeah. But it's only because there's 20 units per 1,000. If either one of those things change, it would change that. So learn the process in case some of the numbers change.
So when you never mind.
So if we're increasing this, and let's say that we had it at 20, let's say we had it at 20 milliunits a minute. That would be 60 milliliters an hour, just because I know how it's mixed. But it was on 60. If he said increase it to 24 milliunits, I would actually go in, and this is physically what I would change on my pump to get what he ordered. Is everybody with me on that? He says increase it to 24 milliunits per minute. I'm going to go in and change my pump reading to read 72 milliliters per hour. Okay?
And then every 15 minutes when you're changing it, what would you do?
You would recalculate it every time.
So if it's 72, I do what?
Depends on what he wants it to go up to. Like usually we start at 1 milliunit per minute and go up by 1 milliunit per minute every 15 minutes until we get them in a good contraction pattern. So you just repeat each time.
To count him every time and make
We have a protocol. And that's usually how he writes it. Started at 4 million units a minute, increased by 1 million units every 15 minutes. Or per protocol, because we have a standard order for that. You increase it until you get a good contraction pattern. Or the baby starts to have problems and you would stop it. Or you reach 20 million units a minute. If you have external monitors, 20 million units a minute is the max that we usually go. If with internal monitors, we can go higher. But if we've got internal monitors, we're trying to figure out if the contractions are strong enough. So how would we know if the contractions are strong enough with an internal monitor? You're going to count what? Montevideo units, and they should be 200 to 250. Okay.
Now that one's already 24.
Right.
So we're not doing nothing.
This is just a math problem, so don't go by that. If I ask you a math problem, I'm not trying to trick you. It was just a number that I plugged in. You could do 24 million units a minute, but we would have to have an internal monitor in and special permission to go above that. So you could do this. You just wouldn't do it with external monitors. Okay. All right. The IV bag reads 10 units of a medication diluted in 500 milliliters of IV solution. The fluid is infusing at 16 milliliters per hour. How many milliunits per minute is the client receiving? So this one works backwards. Same process, just completely backwards of it. All right. So we know that we have 10 units in 500 milliliters, correct? That's what it says, right? We also know that we're infusing that at 16 milliliters per hour. So bear with me. Okay. So when we work this out, it's going to tell us how many units per hour, which is not what it's asking us, but we can get there from there. Okay? So let's work this one out. So 500 times x is 500x. 10 times 16 is 160. So what is x?
0.2.
And what's my label? Units per hour. So how do I get from units per hour to milliunits per minute? All right, let's multiply first, just because it'll make the numbers easier. So if we're going from units to milliunits, how do I do that? Multiply times 1,000, so basically you're moving 3 places to the right. So really we're doing 320 milliunits per hour. Right? Now divide that by 60 to get milliunits per minute. And per minute.
Divide by what?
60. Because you're in per hour, you need per minute. So 5 point. So if I said round to the nearest tenth, your answer would be 5.3. And what's your label? Milliunits per minute. Now on the computer, you just put the number in. And that's pretty much the math. Any questions on that? With this, it's just taking what's given to you and putting it in a format that you can put into your ratio proportion. Okay? Somebody need me to work another one? Okay, let's do one more. The physician has ordered Pitocin to infuse at 20 milli. You want one like this or like this? Like this one. Whoop. Okay, let's just make that one. All right. Let's say that your Pitocin is infusing at 10 milliliters an hour. No, let's do something else. Let's do 12. It's infusing at 12 milliliters per hour. And you have 20 units in 1,000 milliliters. That's what your bag says. Okay? So we know that we have 20 units in 1,000 milliliters. And we know that it's infusing at 12 milliliters per hour. But we don't know how many units that would be. So then you would cross multiply gives you 1,000x. 20, make sure you know that's a unit, not a 0. 20 times 12 is what? 240. 240 divided by 1,000 would be?
That's 240 units an hour.
Yes. Because these cancel out, so units per hour.
And then you divide it by 60.
So if you're given 0.24 units per hour, to get it to units per minute, you would divide by 60, which gives you something crazy like 0.004. But it didn't ask you for units per minute, it asked you for milliunits per minute. So you're just converting units to milliunits, which would be multiplied times 1,000. You get 1, 2, 3, so it'd be 4 milliunits per minute.
What's the final answer?
4 milliunits per minute. Okay.
I need to get that bottom part.
4 milliunits per minute.
Because you divided that
I
part.
divided 0.24 by 60 to get this, and multiplied times 1,000 to get that.
Is that 4?
It's a 4. Okay, what questions do y'all have? Yes. Your 2 math problems will be Potosi math problems. Okay. What other questions do y'all have about the test?
Do you have more examples of that?
There's a
Other math problems?
yes, there's a math review post under Intrapartum that has several more of these type questions, and the answers are behind them. So I will post the PowerPoint before I leave today.
The test is going to be on
Intrapartum and Potosi math.
So when those might be units to milliunits, that's assume that what we did like grams, milligrams.
Yes, the same thing like going from grams to milligrams or liters to milliliters. Same principle. Okay.
And the majority of the test is going to be the stages of labor.
It will be situational based. Now we spent a good bit of time. Let me just grab it and just look at it. We spent a good bit of time on that initial assessment, so what you need to know when they first come in and why you need to know it. We spent a good bit of time on the stages of labor and what to expect at each stage. You need to know epidurals, upside down, inside out, the whole 9 yards. Yes, Karen?
You just changed, instead of changing the 240, you changed the 440, right?
Do what now?
Like I changed the 0.24 to 240.
That's fine.
Okay, you just.
I just did it backwards. Yeah, that's fine. You can do it either way. You can change it from hours to minutes first, or change it from units to milliunits first. Either one's fine. It should give you the same answer. Okay. So you need to spend a lot of time. I mean, this is one module, but it's a heavy module. Okay. So you need to make sure that you know your stages of labor, that you know everything you can about an epidural. If we mention the medication in class, you need to know about it. So Cytotec, Cervidil, we talked about Methergin, Hemabate, Fentanyl, Stadol, all those medications you need to be familiar with. How you would give them, when you would give them. Okay? How you would not give them, or when you would not give them. I think it's done now. Whatever. Just remember these are situational based questions, so it's not going to say your patient's 4 centimeters, what stage of labor are they in. But it could say something like, your patient is in transition, stage 1 transition. Which of the following would be consistent with this stage of labor? Choose all that apply. So you would have to know, it's basically the same question, it's just worded different. So don't let the wording trip you up. Okay? If you know what to expect at each stage and what your responsibility is during that stage, then you're good. Okay? You can use one index card, 3x5, front side only, for the test. One side, just one side. Okay. Okay, yeah. Oh, yeah, review strips, yes.
Remember when you said that if they be itching and didn't do it don't work? He was like, give them new bang. But it just work with pregnant people.
Because
Depends on why they're itching.
I'm going crazy itching.
But it's not medication related. The Nuvain usually works if it's medication related, so probably not. Yeah, I do want